Welcome back, everyone. It's my pleasure and an honor to be here with you today at this symposium. I'm Dr. Haifa, and let's continue. Our first speaker is Dr. Amel Naif Idris. Okay, لحظة. An MD radiologist from Sudan Medical Board, Sudan Medical Specialization Board with an MBBS holder, University. She will discuss differentiation of phylloid breast tumor from fibroadenoma. Dr. Amal, please go ahead. Mic is yours.
Assalamu alaikum wa rahmatullah. Is it
Like,
my screen is shared? Slideshow?
yeah, yeah, clear.
Okay. Good afternoon, everyone. And I'm very happy to be a part from this nice and unique symposium. And I thank you, Dr. Rabab, and our senior colleague for giving us this great chance. I will speak about the differentiation of phylloid breast tumor from fibroadenoma. My objective to have a brief knowledge of fibroadenoma and phylloid tumors, and most of you or all of you know about them. And we will go through a major differences between phylloid tumor and fibroadenoma, and we'll speak briefly about the management of both lesions. Phylloid tumor, also known as phylloid tumor or cystosarcoma, they are rare fibroepithelial tumor, about 1% from whole breast lesions, and they have some resemblance to the fibroadenomas. And also in phylloid tumor, there is an overlap of the imaging characteristic between benign and malignant phylloid tumors. But generally, if a tumor is greater than 3 centimeter or greater, they are reported to be associated with higher likelihood of malignancy. Fibroadenoma, as we all know, the most common solid breast mass in women of all age, and also in adolescents and young adults, they are the most common breast mass. Regarding the clinical differences between both lesion and the age character, phylloid tumor usually between 40 to 50 years of age, and they are generally older than the patient with fibroadenomas. Regarding the clinical and examination of both lesions, they may present as rounded or lobulated, circumscribed, and movable masses. Regarding the growth pattern, phylloid tumor tend to have a rapid growth pattern, and if they are not completely excised, they have a high rate of recurrence. However, fibroadenoma tend to be stable or have a minimal growth interval. The phylloid tumor also, at the size criteria, they are large. They are the presenting size usually between 3 and 5 centimeter. But the size criteria is not a significant discriminator as we have a giant fibroadenoma. Also, if we have a breast lesion, fibroepithelial lesion with evidence of hematogenous metastasis, we will raise the possibility of borderline and malignant phylloid tumors. As common or as general, fibroadenoma and phylloid tumor share many common features clinically, radiologically, and histologically. However, their natural history is often different, and in many centers, if a patient presents with the fibroepithelial lesion and their age for above 40 years of age, they usually do a wide local excision because there is a high
ما
possibility.
كتبتي
لا يا بدهم
اديني الجوال لانه هنا قاعد اسمع محاضرة
ذاكر
من الجوال.
طيب. About the multiplicity and bilaterality, both lesions can be bilateral and can be multiple, so it is not a good discriminator. Regarding radiological differences, we'll start with mammography. Phylloid tumor tend to appear as a high dense mass on mammography, and they tend to be or have a large size, as we mentioned, and usually have irregular outline or indistinct outline, but may have irregular margins. About calcification, it is more common seen in long-standing fibroadenomas, and it appears as a pop corn-like calcification usually, and it is rare in float tumor, and if present, it appears as coarse amorphous calcification.
ممكن ينمله.
About breast parenchyma, if there is distortion or edema of the breast parenchyma, it is usually
كمان رباط
associated with phyllocytoma. Okay, this is an image, CC image from breast. It shows that there is um, a large hyperdense or high dense mass, which has an indistinct outline in the inferior border, and we cannot see its posterior margin. And it is a large, as we mentioned, with some distortion of the breast parenchyma here. So this lesion is most probably suspicious for float tumor. This is a zoom image from mammography. It shows that there is a well-defined small isodense oval lesion, which with internal irregular coarse calcification, and it is a fibroadenoma. This is another image from the left breast CC and MLO view. It shows that there is a huge lobulated mass, which is isodense here to the breast parenchyma, and it occupies almost most of the breast tissue, and it is going with float tumors. Regarding the sonographic feature, and one of the most and one of the important feature regarding the float tumor is the presence of cyst and cleft within the solid mass. The cyst represent necrosis, and the cleft represent stromal invagination or embedded into the epithelial cleft, as we will see in the histology later on. About the echogenicity, float tumor tend to be heterogeneous in echopattern, in the most of the cases. Fibroadenoma generally tend to be uniform hypoechoic, but heterogeneity can be also seen. And sometimes we can see a thin echogenic rim pseudocapsule, which may be seen. And this is an ultrasound of breast. It shows that there is an oval, well-defined, circumscribed lesion, which is parallel to skin with no articular distortion or breast edema, and it is slightly heterogeneous and have a posterior enhancement, and it is a fibroadenoma. As compared with this lesion, which is an irregular, has irregular shape, some border are, I don't know the cursor, yes, some border are angular, and there is some indistinct in the border here, and it is heterogeneous in echogenicity with multiple clefts seen or marked by these arrows, and this is a float tumors. Another image, you can see a mammogram, ultrasound, and Doppler color ultrasound, and we can see a huge hyperdense lesion occupy almost all the brain, all the breast, with lobular outline. And in the ultrasound, it is oval, circumscribed, and complex echogenicity, and it has increased penetrating vascularity. This is another mammogram of patient, and it showed a huge mass with lobulated margin and internal coarse calcification foci seen, and the mass involving almost most of the breast. There is some small, well-defined, well-marginated lesions seen in the inner quadrant, and this patient diagnosed as a malignant transformation of float tumors. And this is a image for comparison, ultrasound comparison between fibroadenoma and float tumor. The first arrow, it showed that there is a well-defined oval, regular shape, hypoechoic, and slightly with some slight heterogeneity, parallel to skin with no distortion, no suspicious features, and it is a fibroadenoma. As comparison with the middle row, there is some irregularity of the border with some indistinct and angulation of the border. Also, there is a microlobulation seen, and this is a case of Phyllodes tumor. And also in the last arrow or last row, there is a mass with angular border, some microlobulation, and it is a Phyllodes tumor also. In MRI, there is no great differences between fibroadenoma and Phyllodes tumors. Fibroadenoma appear as T1 hypo or iso and T2 hypo or hyperintense, and it has a type 1 enhancement with a benign pattern of enhancement pattern. It starts with um, gradual early enhancement with rapid persistent enhancement. And Phyllodes tumor, which also have a low T1 variable T2 signal, and its enhancement is gradual, slow, or can be rapid enhancement. This is an MRI, dynamic MRI with contrast. We can see there is blind-looking lesion here, which is seen to have a sharp margin, and in dynamic image it has a centrifugal enhancement, and it has a gradual type of enhancement, and it is a fibroadenoma. In this image, also it is a dynamic MRI with contrast. It showed that we can see also there is a lesion here, which show also a gradual, if you can see the intensity here, it has a gradual enhancement and a gradual curve of enhancement pattern, and here it is a Phyllodes tumor. That means MRIs have not a great job to differentiate between them. About the histological appearance, fibroadenoma is usually or radially diagnosed with corneal biopsy, but in some cases of increased stromal cellularity, it can mimic the Phyllodes tumor, and we can use the term fibroepithelial lesion يعني يعني as comparison with using the fibroadenoma. We cannot use it because the increased stromal cellularity makes the differentiation very difficult. In Phyllodes tumor, the stroma often protrude into the epithelial lining spaces, forming slit-like spaces or called leaf-like pattern. And this is given the name of Phyllodes, which means leaf-like in Greek. And this is correspond to the cleft seen in ultrasound. Okay, this is multiple images, mammogram, ultrasound, CT, and macroscopic and microscopic specimen. It showed that a well-defined, slightly isodense mass, large, occupying most of the breast, and it is oval, heterogeneous in ultrasound, and show multiple cleft. The cleft can be also be seen in the mammography and on the CT also. In the histology or the microscopic or photomicrograph, there is epithelial lining cleft here, the epithelial lining cleft, which is يعني show يعني it invaginated through the stroma is invaginated through the epithelium cleft, and there is enlarged or increased cellularity detected in the specimen. Okay, about the management, fibroadenoma, as we all know, can safely follow it without further investigation. And even if we need excisional biopsy, the simple inoculation of the fibroadenoma is appropriate and it is enough. In contrast to Phyllodes tumor, it should not be managed by non-operative means of because it is commonly and progressively enlarged, and it may recur, and it has a risk to develop a malignancy. It is classified as Pirate 4 tumor. Moreover, wide excision of the tumor should have an adequate margin to prevent the local recurrence and to provide an accurate diagnosis as it is benign, borderline, or malignant. Take a home message, accurate preoperative diagnosis using the core needle biopsy is mandatory or popular method to distinguish between the two entities and to ensure proper management. However, it has, in some cases, have a lower sensitivity. Phyllodes tumor has a borderline, as we mentioned, malignant potential, and it have a high frequency to recur if inadequately managed. And at the end, we need a multidisciplinary approach in need to distinguish float tumor from fibroadenoma because of the great mimicking clinically, radiologically, and histologically. And in some centers, as we mentioned, they underwent wide local excision regardless of the appearance in a patient with fibroepithelial lesion and its age above 40 years of age. This is my references, and thank you.
Excellent, Amal. Well done.
Thank you, Dr. Amal. Thank you. You are very informative presentation. Thank you. We appreciate your time.
Thank you. Thank you very much.
Is Dr. Hiba Asmat here? Ready? I don't see her name in participant, so I ask.
Did Rahab send her presentation in any of the emails?
No, Dr. Wala is not here. I don't sure.
Very informative, Amal. Very informative and precise and to the point. Thank you very much. Thank you very much.
Thank you, Dr.
We hope to
Thank
see you in the all coming symposium, inshallah.
إن شاء الله يا دكتور، يديك العافية، جزاك الله خير يا رب.
وجزاكم وجزاكم. Who's after Hiba? You
Dr. Zainab Ahmed.
Yes, you can see if...
Yeah, Dr. Zainab is in participant. Dr. Zainab, are you here with us?
Any of you in Sudan?
Assalamu alaikum.
Any of the participants now in Sudan? We want him to call Dr. Rahab directly. If someone in Sudan, to call Dr. Rahab and to ask her to send by email. Okay, no problem. Continue.
Welcome, Dr. Zainab. Are you ready?
Yes, I'm ready. Just I will share my screen.
Okay, try to share.
Yes.
Okay, and now let's continue our program with Dr. Zainab Ahmed, an MD radiologist, and she will cover medullary carcinoma of the breast, imaging and finding. Dr. Zainab, please proceed. Mic is yours. We now see the screen. It's very clear.
Yes. Assalamu alaikum. Good evening. I'm Dr. Zainab Ahmed Hassan. Do you hear me? My voice is clear for you?
Yeah, clear.
Yeah. Okay. Bismillah ar-Rahman ar-Rahim. Today I'm going to present medullary carcinoma of the breast imaging findings.
Welcome, Dr. Zainab.
Okay. Medullary carcinoma of the breast imaging findings. Medullary breast cancer is a rare invasive subtype that is often ill-defined. It's difficult to diagnose with standard imaging like mammography and ultrasound, as it can resemble benign tumors such as fibroadenomas, while it considered aggressive based on its high-grade cytology. Mostly triple-negative subtype with distinct appearance and surprisingly better prognosis than other aggressive triple-negative cancers. Often occurring in younger women, while it can have aggressive feature favorable prognosis is linked to high number of immune cells within tumor. Diagnosis is confirmed through imaging like mammography and ultrasound followed by biopsy. Characteristics, rarity. Account for about 1 to 7% of all breast cancers. Triple negative is the vast majority, about 92% are triple negative, meaning they are not filled by estrogen, progesterone, or HER2 protein. Age, more common in younger women. Genetic link associated with higher incidence in women with inherited mutation in BRCA1 gene. Radiological features, mammography, typically seen as circular oval-type mass lesion with ill-defined or circumscribed margin at mammography. They can be varying of lobulation, while calcification is usually not a feature. The most common finding is solid mass. Shape, the mass is frequently round or oval in shape. Margins, the edges are often well-defined, circumscribed, or have varying degree of lobulation, which can make it look like a benign lesion. Calcifications, the calcification are generally not a feature of this type of the tumor. So what happened after suspicious mammogram? We can do the ultrasound. And ultrasound is often used to get more detailed imaging of suspicious area found on the mammogram. After that, we can take a biopsy. If imaging tests show an abnormality, a biopsy is required for definitive diagnosis. A tissue sample is taken using fine needle or larger core needle, or sometimes through surgical procedure. At the breast ultrasound, the mass can be either homogeneously hyperechoic or hypoechoic with mild heterogeneity. The level of hypoechogenicity can sometimes be marked. At MRI, may show diffuse enhancement post-contrast. For treatment and prognosis, the prognosis tend to be better than for invasive ductal carcinoma. 5-year survival rate of 89 to 95% have been reported. Pathological evaluation. A pathologist examines the tissue sample to confirm the presence of medullary breast cancer and its specific characteristic. Treatment. Surgery, a lumpectomy or mastectomy may be performed, potentially followed by breast reconstruction. Chemotherapy. Chemotherapy is often recommended, especially since the cancer is typically triple negative and cannot be treated with hormone therapy. It may be used to shrink the tumor or prevent recurrence. Radiation therapy may be recommended after lumpectomy to eliminate any remaining cancer cells. Targeted therapy may be used to target a specific pathway involving in cancer growth. Team approach. Management requires an interprofessional team, including the surgical oncologist, medical oncologist, pathologist, and radiologist. This is picture. All this picture is confirmed to be medullary carcinoma. Case 1, at this mammogram, at the right side, we see this picture is magnified, okay? Here we see dense round mass, round nodule, with indistinct margin. As we see here, and the ultrasound, it shows predominantly solid hypoechoic lesion with posterior acoustic enhancement, as we see here. The second case, also, this was approved to be medullary carcinoma. And as we see, this lady, unfortunately, it's so young, 28 years. Also, we see as this magnified image. Also, this lobular mass with well-defined circumscribed margin. It resembles a benign lesion to some extent. And also, at the ultrasound, we see the hypoechoic mass here, well circumscribed margin. Also, at this slide, we show this is mass as a mammogram here, mass with indistinct margin. And at ultrasound, we see this hypoechoic mass with, to some extent, circumscribed margin, mainly at this side. And at MRI, we see this mass, which show contrast enhancement here. Also, this is an MRI study. As we see, this is mass here at slide number A is isotense on T2 steer. Also isointense on T1. And here demonstrate homogeneous enhancement post contrast. And at delay image, we saw the peripheral enhancement. Also, this another slide show MRI of the breast. 48 women also was proved to be medullary carcinoma. This delay phase, we show enhancement peripherally. This is another slide, mammogram. Also, we show well circumscribed mass to some extent resembles a benign lesion, but it was proved to be medullary carcinoma. Also, this other slide showed mammogram show round mass to be an invasive carcinoma with medullary pattern after histopathology. Thank you. Any comment?
Thank you. We appreciate your time and contribution. It was very informative session. Thank you a lot.
Amazing lecture, Dr. Zainab. Thank you very much. Thank you very much. Tertil, are you here? Do you remember now? Do you remember the missing cancer that presenting as circumscribed lesion yesterday?
Yes.
Yesterday we have mentioned metastasis, your topic, topic as circumscribed, invasive, high grade invasive cancer, because it is very rapidly growing and there is no time for desmoplastic reaction. We mentioned papillary, we mentioned mucinous and malignant phylloides, and the remaining is the medullary carcinoma. And this is to emphasize, and as she mentioned, medullary carcinoma associated with BRCA mutations. Those who have high risk cancer having BRCA mutations presented, they have usually medullary carcinoma and usually associated with high-grade invasive cancer. That is why in such group, young age group, benign appearing lesions, we have to be cautious in young ladies with circumscribed masses if it is not very typical of fibroadenoma. If it is rounded, we have to think, if it is rounded, we should not consider it just typical fibroadenoma, rounded lesions. If it is oval and flat and gently hypoechoic, then we might consider it as fibroadenoma. But if it is a bulky, okay, even يعني with minimal lobulations or circumscribed but deeply hypoechoic with posterior enhancement, we have to consider suspicious findings in young ladies, because the BRCA present with cancer in young age group, and those group they associated with medullary carcinoma and with high grade cancer, and both can be presented as a circumscribed benign appearing morphology. So we have to consider other feature. Any subtle suspicious findings, we have to consider it so as not to miss cancer in such young age, because the cancer in this group is so aggressive. And if we give them only 6 months, they will present with extensive malignancy, and we might spread throughout the body. Thank you very much.
Thank you.
Our next speaker is Dr. Abir Al Hadi. Are you here, Dr. Abir?
Abir, let us call her. I didn't see her in.
Yeah, it's not in participant. I don't see her name.
She didn't answer.
Okay, Dr. Rabab, shall we take a break now or proceed with next speaker?
Who is the next?
The next after break is Sarah Ismail Eddin Hamad.
Is she available?
Yeah, I don't, let's take a check.
سارة عصام مفروض بعد البريك إن شاء الله.
أيوة سارة. دكتور سارة is here.
احنا رجعنا قبل شوية من البريك يا دكتورة نورس.
أيوة
اتغير حصل adjustment لأنه the same problem technical problems.
أوكي تاني حصلت لكم.
شوية ما كثيرة
والله.
بس بالنسبة لرحاب أكتر رحاب عثمان.
أيوة.
And
لكن بالريت اللي انتم ماشيين بيه وحكي ده I think she would be able to present later on.
Yeah.
Mm-hmm.
We have some missing. 1 minute, Rahab Abir is calling.
Yeah, okay.
Okay.
الدرج. فصل قبل ما
Is Dr. Sarah Isam here? دكتورة مهيرة؟
Dr. Norris and Dr. Rabab, would you prefer to take a short break at this point till the doctor is answering?
إذا ما في زول حاسي to present. دكتورة سارة عصام is not here currently. ودكتورة مهيرة is not here as well.
And Dr.
So
Abir is not here as well.
she's not answering. She looks like she's trying to call Dr. Rabab. So I guess that we can go to a break, although that you just came out of a break, there's no other option. So let us take a break for like 30 minutes and come back. Yeah?
Okay.
Yeah, so we will meet again in 30 minutes.
Okay.
Okay. You can pause the recording, ya Haifa, until we come back. Amal Nafi or Wala, you can pause the recording until we come back. Just pause.
who's going to present? Sarah?
Nobody's here. Nobody's here, so we took 30 minutes break.
بالنسبة
Sarah,
بالنسبة سارة موجودة. بالنسبة عبير مواعيدها قالت هي مظبطة الشغل بتاع لسه في الدوام. مواعيدها بعد ساعتين من الآن أصلا. مرتبة
فعلا
نفسها على كده. فجو ahead وخلوها تجي في وقتها لأنها هي still at work. still at work.
يس دكتورة. وبالنسبة للدكتورة سارة عصام ردت ليه؟
فمهيرة موجودة خلاص. مهيرة she can present.
Is she here؟ مهيرة ما شايفاها. ما في لا سارة عصام لا مهيرة.
خلاص تجي تقدم ولا أيوة. we can continue discussion. ask.
احنا طلعنا بريك يا ابو ستي، شكلك كنت ما فيش عشان كده ما علقتي.
طلعتوا بريك؟
طلعنا بريك هاي لانه ما في زول، حنتلاقى بعد 28 minutes.
خلاص ما دام طلعتوا بريك it is okay. لكن حاولوا انه to arrange a contact.
Okay, so I'm going to present Dr. Wala Al-Zubair. I'm going to present breast imaging in, oh, it's not working. Yeah, I'm going to present breast imaging in pregnancy and lactation, which is a challenging topic. So breast imaging in pregnancy and lactation is, I'm just trying to move through the, are you able to see my screen?
انت ما انتظرتي يقدموك يا دكتورة ولا؟ مهم جدا يقدموك. وين
ما في المودريتورز ما موجودين.
طيب قدمي نفسك دكتورة ولا.
دكتورة ولاء الزبير. I'm working in University Hospitals of North Midland Trust in UK. I'm a consultant radiologist. I did my training in Sudan Medical Specialization Board. Here I am. So let us proceed to the topic. So breast imaging during pregnancy and lactation present a unique challenge due to physiological changes. The incidence of pregnancy-associated breast cancer is increasing as more women delay childbearing into their 30s and 40s, which is a fact. Roughly 1 in 3,000 pregnancies is affected by breast cancer. Unfortunately, it is often diagnosed late, so early imaging is crucial. The key message here, imaging should never be delayed because of pregnancy. I don't know what is the problem with the presentation.
Also?
Yeah, I don't know what happened. During pregnancy,
it's moving now.
Okay. During pregnancy, glandular tissue proliferate while fat content decrease. So physiologically, this what happened. More glandular tissue, less fat, which lead to increased breast density. Increased vascularity and engorgement can obscure underlying lesions, as we will see in the coming images. Knowing what normal look like in this physiological state is essential before we start labeling findings as abnormal. So radiation safety is always a concern, but the fetal dose from mammography is negligible. It is less than 0.03 microgray, far below any harmful threshold. We still use abdominal shielding for reassurance. Ultrasound, of course, is a first-line modality for palpable masses. MRI should be avoided in pregnancy unless absolutely essential, but it is perfectly safe during lactation, even with gadolinium contrast. So here we are. You can see how dense is this breast, nil fat, I think. So two-view mammography is acceptable when indicated. We usually do mammography post biopsy to see the marker localization.
But if we are going to do biopsy, we will take the lady for mammography first before biopsy. So the aim is to just localize the marker. Sensitivity is reduced because of dense parenchyma, but microcalcifications can still be detected. Advise patient to express milk beforehand to reduce density and discomfort if a patient is lactating. Always remind patient the risk is minimal, the benefit is timely diagnosis. This is a mammogram of a lactational changes in a 47-year-old lactating woman with screen detected calcification in the right breast, as we see in the oval marker. Diagnostic magnification, craniocaudal and mediolateral oblique mammographic views of the right breast show group amorphous calcification. If you can see, I don't know if it is clear for you, at 7 o'clock. So the patient underwent ultrasound of the same area to detect if there is anything can be targeted for biopsy to reduce the post-complication milk fistula from stereotactic biopsy. And the lady underwent ultrasound-guided biopsy of this calcification, which comes as lactational changes, benign changes. This is not my case. This is from Radiographic, a recently published a nice article. I left the link for you at the end of this presentation, 2023 publication. So ultrasound is a workhorse here. It distinguishes cystic from solid lesions, and it is valuable for biopsy guidance. Typical benign findings include galactosile, lactating adenomas. We will see samples of those lesions. Remember, hormonal changes can mimic disease, but only histological confirmation is the diagnostic tool. So on those two images retrieved from the same article, we can see how much is the glandular tissue in both pregnancy in the A image and lactation in the B image. So if you are aiming to see something which is not palpable in this, I think it is very difficult. MRI in lactation, definitely MRI in pregnancy is contraindicated. However, it could be, so if the patient is diagnosed as cancer during pregnancy, we usually wait until delivery and then we can do MRI when she is lactating. So it is safe during lactation, though background enhancement can be marked. If possible, schedule it 3 to 6 months after weaning for better clarity. However, it is not contraindicated. We still do this if the patient is lactating. Gadolinium excretion in breast milk is minimal. Breastfeeding can continue without interruption, and this is very important to reassure the patient when asking for MRI. So here we can see samples of MRI during lactation. So the down images C and D are the normal population or general population normal MRI. The first row A and B images are in lactating women. So we can see how much is the parenchymal enhancement difference between both images, which is reducing the sensitivity of detecting any satellite or subtle lesions. Typical benign entities. So in this image here, mammogram and ultrasound, we can see a rounded lesion, which is very dense in mammogram, and it shows a typical fluid fat level, which is diagnostic for galactosile. We will see some other entities like lactating adenomas. It is very common, by the way. We are in every 2-8 clinic. We have one visitor from either lactating or pregnant with a palpable lump because they can feel it more. Sometimes they have fibroadenomas, which is not felt during normal life. When they come pregnant, they will feel it because breast itself is become denser, and moreover, physiological changes during pregnancy increase the size of the lesions. So lactating adenomas are solid, well circumscribed vascular masses. We see also mastitis and abscess. We will see cases for those. Let us go for the cases. So here is some cases. The first one is galactosile. We already see that. The next one is a lactating adenoma, well defined. It is similar to fibroadenoma. So, however, the lady will come saying that I just felt this after pregnancy, after delivery. And it is big and very vascular. So usually fibroadenomas are not very vascular. This is the one differentiating thing, and Dr. Rabab will have a talk after this, most likely about this. We have the fibroadenoma also a common presentation in pregnancy and lactation because patients will have increased growth of the lesions. We have also common peripheral mastitis, which is a non-abscess forming mastitis or inflammatory reaction to the breast. Biopsy. So biopsy is safe during pregnancy. So if we find if a lady comes with any of these solid masses, do we need to do biopsy? So I have last week I have a case in her 40 day after delivery, and we have a very suspicious mass. We don't know to biopsy or not. So we took a advice of our senior radiologist, and she said let her come after 2 months. So we can't wait because those ladies, if it is suspicious for cancer, they have a very rapid growth of cancer and benign lesions. So if we decide to do biopsy, what we are going to do, we will tell the patient to express her milk and simply come for a normal biopsy. But we should warn the ladies with a possibility of fistula, which is common. And we will have talk more in the coming cases. So this is a typical atypical galactosile in mammogram. We can see well circumscribed calcified mass in the right central lateral 12 o'clock region, which show amorphous calcification. And her ultrasound showed a extensive shadowing from the calcification. So this lady, she is, for me, if this is in our department, if we didn't find a mass, we will not go for biopsy. But it is in wherever she has been presented, she is regarded as BIRAT 4A. Ultrasound guided aspiration yielded milky fluid diagnostic of galactosile. Subsequent core biopsy, I don't know why they did that, but if it is BIRAT 4A, then they will do a biopsy. So biopsy due to persistence of bulbal mass after repeated aspirations show benign lactational changes. So we have a lot of ladies who come through their first 4 months after delivery with recurrent galactosiles. We will aspirate and then reaccumulate, and she will come back for symptoms, aspirate again, but we never did biopsy. So you will have more insight on this because we are not BIRAT people. In MRI, so similar to you have this with ovarian ovarian cystic ovarian fatty masses, which are dermoids. So you will have fatty fluid levels, the same here. So if you see any fatty fluid level in MRI breast, this is diagnostic, and even in mammogram, this is diagnostic of galactosile. And it is usually incidental findings. We are not doing this MRI for those cases. This is a common presentation of a patient who have well-known fibroadenoma, and you can see how this become a spongy shape after pregnancy, and this is common. So fibroadenoma itself will increase in size and will have changes in appearance, like this sample of case here, spongy shape case. We don't need to do anything for this lady at this point. This is another case in lactation, also a same lady who had the fibroadenoma before pregnancy, and this is in lactation. It showed similar to increased ductal growth. It is not ductal growth, it is just the growth of the mass itself. So continuing with the benign changes in the breast during pregnancy and lactation. So this is a mammogram of axillary tissue in a 36-year-old lactating woman. She is high risk screening with a family history of breast cancer. So her mammogram showed dense tissues, symmetrical in both breasts. We don't feed those, but we bring ladies for just ultrasound reassurance. Her ultrasound showed axillary tail lesion similar to the breast. So you can see it in C image. This lady, she did also MRI as a screening tool for her as well. And this MRI show similar finding of breast tissue. You can see the similar enhancement and consistency of the breast in the axilla. So this is diagnostic for axillary breast. Sorry, this lady, she underwent biopsy because they regard her as BIRAT4A, and this confirmed breast tissue with lactational changes. Also, in our practice, we are not biopsying typical axillary breast. This is also axillary breast, but normal, not in lactation. So this lady is a 33-year-old lactating woman presented with palpable abnormality in the left breast. Her mammogram, not shown here, showed no underlying abnormality. Ultrasound image show oval hypoechoic mass, very superficial, just under the skin. This mass reported by the patient herself. The mass was recognized as BIRAT4A, and ultrasound-guided biopsy was subsequently performed. Photomicrograph show pores with variable size acini and variable dilated acinar units. I'm not very well knowledgeable, to be honest, in pathological slides, but it is very informative. Lobules containing intraluminal secretions consistent with lactational changes. They said this is, we can see in the arrowheads. So the oval shape, if you have a pathologist here, it would be very helpful, but I don't think so. But those
Dr. Nadia
shape,
with us.
Dr.
Nadia is
Nadia,
here.
please help us.
You are doing very well.
Thank you very much. I really want to know because we have this in our exams. If we have any exams related to breast, we will have slides from breast lesions or normal breast tissue, and we need to have a little bit of information about that.
Yeah, it's very good. Until now, you are saying everything, and you have to see that there is no pleomorphism. That the nuclei are all nice and small. You see there is nothing that makes you scared this is malignant.
Okay.
Yeah, just looking at it, the architecture is changed because of the lactational changes. But look at the nuclei of cells. They are beautiful, small nuclei, no pleomorphism there. There's no change in the nuclei to make them look malignant. This is what we mean by pleomorphism. Do you know the term?
Yes. Yeah. Different shapes
So
and
there is
different
no
size.
pleomorphism. The nuclei are nice, regular. The thing is, and you can see the secretions where you have the stars in the lumen.
Yeah, yeah.
The black,
Yeah, it
the
looks
black stuff.
these purple dots looks uniform size, uniform shape. Yeah.
Yeah. Yeah.
Nice.
It seems you're doing well. I will interrupt if anything
Thank you.
goes wrong.
Yes, please.
Okay,
We
lovely.
will be
لا
happy
very
to
good.
interrupt. Thank you.
طوالي إن شاء الله.
Thank you very much. So this
عفوا.
pathology result was a benign lactational changes. So this is, we have this dilemma always, benign breast lesion in lactating or pregnant lady and look irregular. We do a biopsy and it comes as lactational kinks. It have different colors and different shapes. So this is the lactating adenoma. So 26-year-old pregnant at 28-week gestation, presented with palpable lump in the subareolar region of the breast. Ultrasound image show oval hypoechoic mass with microlobulated margin and posterior acoustic enhancement. This was categorized as BIRAT 4A. Ultrasound guided biopsy was subsequently performed. Photo micrograph show markedly hypercellular course and marked hyperplasia of normal appearing lactational tissue in the right, consistent with a lactating adenoma. Note minimal intervening stroma due to marked acinar expansion. However, the basement membrane remained visible, arrows in the right. A myoepithelial cell layer is present but inconspicuous in the arrowheads area due to increased size and volume of epithelial cells with finely vacuolated cytoplasm due to hematoxylin statin. Original magnification shown in this view here. So adenomas, we don't biopsy adenomas in lactation or pregnancy. And then we will have Dr. Rabab at the end talk about this in their practice. Then let us go to the pregnancy-associated breast cancer. So it is a cancer diagnosed during pregnancy or within 1 year postpartum. It often presents as higher grade. Node involvement is common, unfortunately, mostly due to diagnostic delay rather than biology, because there is no increase in incidence. We will see later in slides. When adjusted for stage and tumor type, prognosis is similar for non-pregnant women. The key takeaway here, pregnancy does not worsen the prognosis, but delays does. So what is the symptoms and signs? So patients came with usually with painless mass or skin thickening because they came high grade. They can, if they are lactating, they will come with a milk rejection sign. So milk rejection sign mean that the baby refused to nurse from the breast having the cancer. So it is not something scientific, but it is known to have this with high suspicion when the patient come with this symptom. But also one of the symptoms is the lady will come to say she has increase in breast weight in one side. So current evidence, pregnancy-associated breast cancer generally does not worsen long-term prognosis when adjusted for stage and tumor biology. Historically thought to have poorer outcomes, now it is linked to diagnostic delays and advanced stage at diagnosis, not to the pregnancy itself. Key points: tumor stage, grade, and receptor status are the main determinants of prognosis. No evidence that pregnancy accelerates tumor biology. Multidisciplinary care is essential to optimize maternal and fetal outcomes. Data snapshot studies show 5-year survival rates are comparable to non-pregnant patients when matched for stage and treatment. Clinical takeaway, pregnancy should not delay treatment. Prognosis is primarily influenced by tumor factors, not pregnancy. So here in our practice, we sometimes we ask the lady if she want to terminate pregnancy, and some of them yes, some of them no. So we usually have the same protocol of management to the non-pregnant ladies. Diagnostic algorithm, a palpable. So our approach is straightforward. Palpable lump, ultrasound. If suspicious, core biopsy. If malignancy confirmed, stage carefully with minimal radiation. MRI is best reserved for post-delivery evaluation. So we have two samples of ladies. One of them coming early breast cancer. She terminated her pregnancy because she want staging and everything go through. And one of them, she was in her 27 week. She continued, but we did everything. We did CT scan, non-contrast. We did MRI, and I have those cases with me at the end. Imaging modalities. So ultrasound, high sensitivity for masses and nodules, and it is the first line imaging. It is safe, definitely, no radiation risk. But we are doing mammography under abdominal shield, safe with abdominal sensitivity low due to the, increased density. But as I said earlier, we don't do mammography for diagnosis. We usually do mammography for marking localization of the marker. Core needle biopsy. It is safe. The only thing we are fearing is avoid milk fistula. And what is the solution? Express milk before procedure. Even mammography, we ask the lady to express her milk before the procedure. Use aseptic technique as usual. Avoid infection risk. Clip markers may be used. We are using, not maybe. So we are using clip markers. Staging and further imaging. We do CT chest, abdomen, and pelvis. Post-delivery, we are doing pre-delivery, but without contrast. We avoid gadolinium during pregnancy. We consider PET-CT postpartum only if essential. Yes, we don't do PET-CT in pregnancy. Prevention measure of milk fistula. Stop lactation 1 week prior to biopsy. Empty the breast immediately before biopsy. Consider bromocriptine 2.5 milligram, BD or TDS. Challenging in triple assessment, as we know, all is challenging. So clinical examination is challenging. Increased breast density due to physiological changes make physiological examination more difficult. Imaging, mammography as usual, less sensitive, and concern about fetal radiation, but no concerns. Complications of biopsy, and we discussed this earlier. So pregnancy-associated breast cancer in a 36-year-old pregnant woman at 13 weeks gestation who presented with a lump in her left breast. Ultrasound of the palpable area of concern show irregular hypoechoic mass with angular irregular margins. Ultrasound images of the left axilla show morphology abnormal lymph node with cortical thickening and loss of fatty hilum, similar to the breast mass itself with indistinct margin. And the mass in the mammogram showed pleomorphic calcification, correspond to the mass seen on ultrasound. So the breast mass was categorized as BIRAT5. Ultrasound guided biopsy confirmed the diagnosis of grade 3 estrogen, ER positive, PR positive, ER HER2 negative, invasive ductal cancer. The lymph node was biopsied and demonstrated metastatic carcinoma as well. Photomicrograph of the left breast mass specimen show infiltrative hypercellular core, an irregular angulated nest, and cores of tumor cells infiltrating stroma with desmoplastic reaction. We will need Dr. Nadia in this. So a haphazard arrangement with mitotic figures noted. Note the intact myoepithelial cell layer in the intralobules for comparison. So we can see a lot of cells, polymorphic cells, I think, here. So this image is typical to any cancerous image we see before, a lot of nuclei, isn't it?
Yeah, it is much more hypercellular, but honestly, on high maybe I need a higher power so that you can see the pleomorphism. But you can see the arrangement of the cells. You don't have the architecture of the normal breast lobule anymore, the acini
Yes.
and the ducts. And you have just sheets of cells that, as the arrows are pointing here, you have these sheets of infiltrating cells. But honestly, at this power of I cannot really say, is this because I thought of lobular even.
It is invasive
Look,
ductal.
like in its invasive ductal, yes. I need to see higher power and to see other areas. Definitely. But this is not normal. What I can say is that this is not normal arrangement of cells in a lobule.
Yes, it is very different to the image I seen before in the physiological change. Yes.
Yeah.
Okay, we'll proceed.
Tamam.
Thank you. So this is an MRI. This is a pregnancy-associated cancer as well in a 32-year-old lactating woman. So it's not pregnant, she is lactating, who presented with a lump in her right breast. Mammogram show focal ACP3 with associated architectural distortion and amorphous calcification. Ultrasound image show corresponding irregular hypoechoic mass with angular margins and categorized as BIRAT5. Ultrasound guided biopsy result confirm invasive ductal carcinoma grade 3. ER positive, PR positive, and HER2 positive, triple positive. Maximum intensity projection MRI shown irregular enhancing mass consistent with the biopsy proven cancer, single mass, but I think size is more than 3. No lymphadenopathy was seen. Marked background parenchymal enhancement also noted, but because there is a mass, so parenchymal enhancement here doesn't do any problem in diagnosis. So this is usually for staging. So here we need to know if there is any other satellite or any other contralateral breast lesion. This is a 31-year-old woman who presented with a left lump and she is pregnant. So mammograms show irregular mass in the left breast with indistinct margin that correspond to the overlying triangular marker. Ultrasound image show irregular hypoechoic mass with angular margins graded as BIRAD 4C. Ultrasound guided biopsy result reveal grade 3, ER negative, PR negative, so triple negative invasive ductal carcinoma. The patient subsequently discovered that she was pregnant, but decided to terminate the pregnancy. MRI performed after termination to evaluate the extent of the disease. So the MRI show biopsy proven malignant cancer with susceptibility artifact from biopsy clip, no lymphadenopathy seen. Post-neoadjuvant chemotherapy showed no residual mass or complete radiological response. The final pathologic results show benign breast parenchyma with treatment effects and 3 negative sentinel lymph nodes. I'm sorry, I need to just see who is knocking the door. I will come back just a minute. Excuse me for the interruption. Sorry for that. Last entity in breast in pregnancy and lactation, mastitis and abscess. It is common in lactating women. Ultrasound show usually complex fluid collections and hyperemia. If symptom doesn't resolve with antibiotic, repeat imaging to exclude inflammatory carcinoma is needed. Never assume persistent mastitis is purely infectious. So here we can see peripheral mastitis in 28-year-old woman presented with skin erythema and pain after discontinuing breastfeeding. 3 weeks earlier, ultrasound image shows skin thickening and subcutaneous edema with no discrete fluid collection. Given the patient's presenting symptoms and imaging features compatible with mastitis, BIRAD2 category was assigned. The patient improved with antibiotic treatment and received clinical follow-up to resolution. So the key note here is if the patient came after antibiotics for follow-up and the symptom persists, then we need to consider suspicious edema and we need to do biopsy. We usually do skin biopsy, skin punch biopsy. So this is acute purpular abscess in 26-year-old lactating woman who presented with skin erythema, warmth and pain. Grayscale ultrasound show irregular complicated fluid collection. Image show hyperemia surrounding the fluid collection. Ultrasound guided aspiration yielded purulent fluid. Culture show methicillin resistant Staph aureus, which is common with lactation Staph aureus. This lady has the pre-pregnancy diagnosis with granulomatous mastitis. So here also a note, the pregnancy and lactation increase recurrence risk of granulomatous mastitis. So this is a 32-year-old with a history of biopsy-proven granulomatous mastitis. Now 4 months pregnant, presented with right breast pain and drainage. Gray scale ultrasound show complicated fluid collection or phlegmon with tubular extension to the skin. So we can see here there is tubular extension to the skin. The other image show increase in vascularity. Clinical follow-up and management was recommended given the patient symptom and history, reporting diagnosis of granulomatous mastitis. So nothing to do, just follow up. This is COVID-19 period. It was a horrible period for us. So every lady with bilateral lymphadenopathy or increased cortical thickening of the lymph nodes in a patient with breast cancer, do we need to biopsy or not? We end up biopsying every lady with breast cancer and bilateral axillary ultrasound. And those ladies, usually they have just reactive changes. This was reactive, by the way. So when to stage? Stage 2 or above, this is important. Suspicious symptoms like bone pain or dyspnea. Safe options to stage or to start with during pregnancy. Chest X-ray with children, liver ultrasound, whole body MRI, no contrast. We are doing this, so this is our practice here. Use with caution, bone scan and CT, avoid unless critical. We need to do one of the ladies pregnant, we need to do bone scan. And she was metastatic because they need to decide from the beginning where to go in management. Consider fetal exposure risk in all cases. So talking about screening guidelines in ladies who are pregnant or lactating. So in pregnant and lactating women, this is ACR guidelines, which most of you using those guidelines. There are little bit of difference in our practice. So in pregnant and lactating women aged 40 in your case and 50 in our case in Europe at average risk. So normal population with pregnancy or lactation. We don't do mammography in pregnant ladies, but in lactation, yes. With digital breast tomosynthesis, this is American, is recommended in those ladies who are pregnant or lactating. Average risk in women with dense breast, supplemental screening with whole breast ultrasound, as Dr. Hiba showed us, automated ultrasound may be considered with recognition of the increased false positive rates in this modality. MRI may be considered for supplemental screening in lactating women only. MRI is not recommended for women who are pregnant, we know that. In patients at high risk, age 30 years and older, here in UK, 25 years or older. Mammography, we do only mammography. They do mammography, and digital breast tomosynthesis is recommended for pregnant and lactating women. This recommendation pertains to women with genetic mutations associated with an increased risk of breast cancer and their untested first degree relatives, and women with a lifetime risk of at least 20%. So those who are categorized as high risk. So why they are tested with a first degree relative with breast cancer, lifetime risk of 20%. The recommendation for women with a history of undergoing mantle chest radiation therapy, this is also in this category of high risk, administered before the age of 30. To start screening mammography at 25 or 8 years after therapy, whichever is later. So if she was 30 years and then she got therapy for lymphoma, then we count 8 years and we will start the screening. So US may be ultrasound may be considered for supplemental screening during pregnancy when MRI is contraindicated. Breast MRI is recommended in lactating women, but may be delayed until 3 months after cessation of breastfeeding if the total planned time period for breastfeeding not prolonged. So I already covered the next slide, which is NHS screening. So those are cases I already present this before if you attend that. So I had a webinar about breast cancer with the pathologist and surgeon. So this is just sample from our practice. 34-year-old pregnant woman, 32 weeks, come at 32 weeks. She presented with the right upper inner quadrant breast mass and multiple lymph nodes involvement. So this is her ultrasound. And this is her mammogram. So mammogram, as I already said before, we just use it to localize the marker. And this is her MRI before NACT, and I didn't bring the post-NACT, sorry for that. So post-NACT show a complete pathological response. So this lady diagnosed as grade 3, non-specific ER negative, PR negative, HER2 negative, triple negative, present with nodes. So new adjuvant chemotherapy started. Then she was for mastectomy and radiotherapy for the breast and axilla, and nipple preserved because it was more than 20 millimeters from the nipple. This is the next lady is 44-year-old woman, came 9 weeks pregnant with palpable mass in the right breast. This was her mammogram. Anybody can pick anything in this. Any volunteer. It's very challenging. So we did tomosynthesis, and I think here it is. There is a clue if anyone is happy to proceed.
Outer, lower,
It's outer, upper. This one.
upper. In the
Good.
CC view, it is outer. But in there is added density, yes. Now the distortion is seen. Distortion
Yeah.
there is the contour of the outer breast fat glandular interface. I thought it is
Yes.
corresponding to the asymmetric density in the lower part.
Yes.
But
I
yes,
didn't
now
bring the
now yes,
contralateral. Yes, you are right.
yeah,
If I bring the
but the
contralateral, you will
density,
say the same.
yeah, because the density within the same breast is different. The lower portion is more dense, but now when you point it, yes, there is area of distortion, subtle area of distortion in the upper breast. And
Yes.
but in the CC view, the distortion is clear along the contour.
Yes. So this is her ultrasound. So ultrasound show the mass in the upper outer and a lymph node with cortical thickening. This is her MRI. So this patient, she came 9 weeks pregnant. So we did MRI because she preferred to deliver the baby or terminate pregnancy. So she terminated pregnancy and continues her medication. So this came as grade 2 N2 M0. Wide local excision, sentinel lymph node biopsy, and this is her pathology. And wide local excision, sentinel, two nodes with micrometastasis. They re-excise the area, no residual tumor. And then she did whole breast radiotherapy. Key learning points. Breast cancer in pregnancy require multidisciplinary approach, radiology, oncology, and obstetrics, and surgery, sorry. Timing of the delivery is crucial to allow cancer staging and treatment. Because if the patient is like this patient 9-week pregnancy, and we need to know if she has a metastasis or not. We cannot start any treatment until she delivers. So that is why she preferred to terminate her pregnancy. Triple negative breast cancer require aggressive systemic treatment. If you have oncologists, they will talk more about that in this scenario. Nodal involvement can significantly impact treatment decisions and prognosis. So key takeaway, imaging should not be delayed. Mammography safe with negligible fetal radiation. Ultrasound is first line modality. MRI is contraindicated in pregnancy, safe in lactation. Core biopsy is safe, except breast milk before imaging or biopsy. So this is the article. You can find it in the slides when I will share. Thank you very much. Discussion?
Thank you very much. Yeah, very insightful, and you really exceeded the expectations. There is nothing to be added,
Thank
and
you.
I have learned a lot. You see, there are updates. You have mentioned a lot of updates to me.
Thank you very much. It was very valuable when it was
No, it is very
presented
impressive.
with pathology
Very
and
impressive. Yeah, very impressive. Very impressive. Really, very impressive lecture.
thank you. So
And
do we
very
have any
updated.
questions? Thank you, Dr. Rabab.
But regarding the behavior of breast cancer, earlier a lot of talk about during pregnancy, the pregnancy associated cancer is aggressive type of cancer generally before, and now you have mentioned they concluded that it is not the truth.
Yes.
This is
There was
this,
a lot
yeah,
of changes from previous
yeah.
practice.
Yeah, the
Yeah,
previous
I
practice
was
they
yeah,
were all yani they do mention that always mention pregnancy is associated with aggressive type of cancer, associated with aggressive type, and the presence of hormone related yani increase the progress of the cancer is it will be rapidly progressing due to the hormone related pregnancy. There were a lot of talk regarding this issue, but now you
it
have
is
mentioned
changed.
that it is not. Yeah. This is new.
We have a lot of my practice changed a lot with regard to this topic itself, and it is very we fear any patient with lactation or breast pregnancy with cancer. There is a lot of cautious about treatment plans, but now it is like we have guidelines which is similar to, it is more better for us because 1, 2, 3. Before it was a lot of debate anyone and their practice. But now there is a guidelines. It is same as pregnancy, non-pregnancy associated cancer.
Yeah,
The,
that means
the only
yeah.
thing the only thing is the staging, when to start and what to do. But anything else is similar to non-pregnant, which is changed. It
So
wasn't like that.
yeah, so they before if she doesn't like to terminate her pregnancy, no treatment.
They will, but it depends on what they want. If the patient need, for example, to do surgery, we need, and the patient having more than 3 lymph nodes, we need to do staging CT. So she need to wait until after delivery, or she can do before. And if she has any suspicious sternal high,
They are not doing CT
they are doing
during
CT
pregnancy.
without contrast. They are doing CT without contrast, which is less sensitive, as you know.
But I think and even for pregnant lady, uh, some practice they are doing abdominal CT even for acute abdomen
Here we
with
do
contrast. With
MRI whole
contrast.
body. Here
Yeah,
we go for whole body. We don't do CT usually. It could
yeah,
be done,
yeah.
but we don't do.
I said some practice also for us.
Yes, yes, it is
We
different.
we used to do MRI for pregnant lady. Okay, MRI without contrast for appendicitis, for acute pancreatitis, and acute abdomen in general. We used to
Mm.
do MRI without contrast. But I have done also in other hospitals. Okay, during my practice, we have done some of the CT with contrast for acute abdomen because يعني, some of the acute abdomen diagnosis cannot be well demonstrated on
Yes, for
non-contrast
acute,
MRI.
yes, for acute we do
Yeah,
here also.
because
We do CT.
yeah, because the يعني they overweigh the woman health over the child health.
Yes, it is not contraindicated in acute setting. I mean in staging setting.
I,
But in acute setting, yes, we are doing CT scan
no,
with contrast.
I'm trying to compare. I know. I'm trying just to
Yeah.
compare. If they are doing in acute setting, why not to do for staging to treat the patient? Yeah, for
They
breast
just
cancer
try
and to delay.
to be cautious, but if they need, they will do. They will try to be cautious. Usually ladies they refuse, by the way. So we go
Ah,
for
they
whole
refuse.
body MRI. Yes. Usually they refuse.
Mm.
We need to
But
discuss with them the
but
whole the thing.
whole body MRI without contrast.
Yes, yes, we are doing whole body. So this lady, the first one, we did whole body MRI without contrast.
Mm. Is it useful
Uh,
in your
the lady
practice?
has.
In your practice,
It is at least it will we can say no bone abnormality, if that was a dilemma from the beginning. So we just
because
answer our questions.
sometimes it will put you in a dilemma
Yes.
to see some yes, to see some lesion and you need
Yes,
to characterize it further. Is it a benign or malignant?
but usually
Okay.
it is very rare, so I don't have even a lot of cases to compare.
Mm.
It is very rare as a
We will
cancer
ask you
itself.
to we'll try to collect for us some cases like this
I
because it
will
is really
I will.
important. Yeah, important. We need to learn about this issue more and how to deal with it because these are really challenging.
Yeah, I will, inshallah.
Because يعني I have one case before contrast it was bone lesions. Without contrast it was يعني not we couldn't tell if it is neoplastic or benign. You see, especially when are few lesion, not or single lesion. If it is multiple, numerous multiple so it will be straightforward. But when an isolated metastasis or single lesion, it will be difficult before giving contrast to tell exactly what is
Yeah.
going on, unless, and especially if it is bright on T2. If it is intermediate or low on T2, you will go for metastasis. But if it is high, you will be in a dilemma. Is it hemangioma or metastasis? And it is a solitary
Okay.
lesion. Yeah. But try to collect for us some cases like this, please, to
Inshallah.
help
I
to
will do.
help us to help us regarding this issue. Is really
Inshallah.
challenging for us. Yes, before we know that it's okay. I have no experience of a single case developed like milk fistula. Okay, but
Yeah, me too. We don't
since
have this. I didn't see
since
it.
since long time we used to present it in our lectures, and we know that there are precautions regarding lactating and pregnant women regarding the biopsy, and we should not rush for biopsy regarding this issue. And also, uh, squeezing milk will reduce the density on mammography before mammography, and should be also before biopsy to reduce the risk of fistulas. This in the literature since long time, but the new issue regarding their management, okay, and the behavior of the cancer itself, these are new.
Yes.
Mm.
Yes. So even milk fistula, honestly, if it is away, like upper outer, upper inner, away from the nipple, it is not a big issue. It is an
Yeah,
issue when
minor
it is
duct.
very,
Yeah,
yes,
minor duct. If it is close to the major duct, it will be big issue. But
yes,
for me, I have never seen a single case with milk
yes, me too.
fistula.
Me too. I just find it
Yeah,
in the
I
literature, but
think
I
it is
didn't see.
rare. It is rare.
Yeah.
It is not a common thing. Dr. Latifa, are you there? She might help us more because she has a lot of experience regarding, she's doing biopsies, a lot of biopsies. She's not available. Dr. Latifa,
خلينا أشوف لك participants. لا ما أظن موجودة.
لا ما في. I
أيوة.
think she's not available now. Okay, any of the attendees, if you have experience, Dr. Hiba is not available. Magdalene, she's doing biopsies. Do you have experience regarding this issue?
The audience are tired because it is a long day.
Okay, no problem. We can proceed.
So
But it is really interesting and very, very, very useful. At least to me.
Very
I,
enjoyable.
يعني
Very enjoyable.
very
Really.
enjoyable, very enjoyable
Yes.
lecture. It
Alhamdulillah.
added a lot. It added a
Yes,
lot
thank
to
you.
us. Yeah.
Yes,
Thank
yes,
you.
definitely.
السلام
thank
عليكم.
you very much. عليكم
عليكم
السلام.
السلام.
معلش I'm coming late.
No problem. I asked you about the milk fistula. I said to Wala, yes, we know since long time the pregnant lady and biopsies. We are trying to avoid biopsy in lactating and pregnant women to avoid milk fistula. But for me, I haven't seen a single case with milk fistula. Wala, she said the same. She has the same experience of not facing any milk fistula. I said to her, let us ask Dr. Latif or other who are practicing breast biopsies.
والله احنا سبحان الله unfortunately
last 2 years تقريبا كانت جاتنا واحدة كيس like this. هي أصلا كان عندها بريست lump واتأخذت لها بايوبسي على أساس إنها هي to confirm what is this, and she developed milk fistula. كانت discharging for a long time. كانت كيس بتاعت مستر دبورة بتذكر. فبجد حاجة كده يعني سبحان الله painful، يعني painful psychologically، يعني لأنها for long time discharging. فبجد حاجة كانت صعبة.
And where
So
was
you
the
have
lesion, if you remember?
الليجون unfortunately لا طلع جلاكتوسيل.
لا حول ولا قوة إلا بالله، ما تستاهل. ما في
يعني
داعي
that
ذاته
is
كان
why
لل...
I think that is the why. No, I think this is the predisposing to the milk fistula. So it is already related to a duct,
أيوة يلا هي
and they
لأنه
open.
هي شكلها عملت لها سكان وإنها اتخذت إنها suspicious واتأخذت البايوبسي على هذا الأساس.
If they aspirate, it will relieve, and maybe it was thick fluid or
I think
something.
اتأخذت time. هي اتأخذت منها كور بايوبسي، فالحتة بتاعت الانترنس بقت عبارة عن orifice of sinuses، فبقت
So it
for
is central, yeah. It is central. It is anterior central, most
أيوة.
likely, yeah.
لكن شفتها مرة واحدة سبحان الله، يعني ما حصل تاني.
The lesion is anterior, yeah, anterior central, around the nipple
أيوة around
area.
برا في برا
Large lactiferous duct, large lactiferous duct.
أيوة central ducts.
Yeah, central ducts are more predisposing to fistula rather than the small peripheral ducts. And one of the challenging, you have shown one of the cases of your cases, Wala, with those polymorphic calcifications, just representing lactation changes. This is one of the challenging also.
Yeah. It is very interesting. This is from radiographics, not our practice, but we usually do the biopsy for those ladies. Even if they are lactating,
because you don't know if it is cancer or lactation changes. There is no other clue to say based on image, because the changes are there.
Yes, and they are very progressive. So if we just wait, we will come with a grade stage. We don't want that. So always it is challenging for us.
Yeah, but we have to put in our mind. And also there is one challenge when you have taken the biopsy, because definitely the area it will be mixed, the malignant lesion as well as lactation changes, and you don't know if you have taken from the lactation changes area or from the center where the cancer cell. So I think those people or those group of patients, we have to follow them. If the pathology concordant, even if it is concordant, demonstrate lactational changes, I think we have to follow them to make sure that not associated with underlying malignancy. In my opinion.
Yes, I think so. We usually cautious with calcification in general, even if it is benign looking.
Okay, let us proceed.
Okay, so Isra will be taking over the presentations, and we will see who is available for next presentation.
I think Abir is here.
Hello, thank you. Thank you, Dr. Wala Zubair, MD, FRCR, Consultant Radiologist, Breast Imaging Specialty, University Hospital of North Midlands, Trust, UK. Thank you a lot for the very nice presentation. Next, we will stay with Dr. Abir Al-Hadi, Consultant Radiologist, Aster Clinic Hospital, Fujairah. Dr. Abir, please, can you proceed?
السلام عليكم ورحمة الله تعالى وبركاته.
وعليكم السلام ورحمة الله وبركاته. مرحبا عبير.
مساء الخيرات عليكم أساتذتنا الأجلاء في الراديولوجي، سنايرنا وزملائنا. السلام عليكم ورحمة الله تعالى وبركاته. مساء الخيرات عليكم، إن شاء الله كلكم بخير وعافية. وأول حاجة يا دكتور أنا ما كونسلتنت، أنا لسه سبيشاليست حديتونا.
In our eyes, you are a consultant. Don't worry. Don't worry.
I just want to share, but I think
me make you
Doctor,
co-host. Let me make you co-host.
I'm seeing the screen of my previous colleague, the previous presentation.
I will make you co-host and now you can share. Then I will stop share. Are you able to share? We just check that again.
Okay, I'll try. Okay, are you able to see my screen?
Yes.
Oh, thank you.
Proceed.
First of all يعني أنا حابة أشكر كل القائمين على المجهود العظيم الجبار ده، يا ربنا يجزيكم خير إن شاء الله، وإن شاء الله نقدر نقدم حاجة تكون خفيفة الظل يعني وتكون مهضومة للناس. I'm going to present invasive lobular carcinoma of the breast. As an introduction, invasive lobular carcinoma is the second most common invasive breast cancer after invasive breast carcinoma of no special type. That is to say, invasive ductal carcinoma, not otherwise specified, accounting for 5 to 15% of all invasive breast cancers. Clinical and imaging diagnosis of invasive lobular carcinoma remains challenging, and this can lead to missed or delayed diagnosis. There is a greater rate of contralateral breast cancer in invasive lobular carcinoma compared with invasive carcinoma of no special type, with a 5-year rate of bilateral cancer of 8%. Half of these are synchronous, and the other half are metachronous tumors, that is to say, detected after 6 months or more from the first tumor. Clinical presentation. Clinical signs of invasive lobular carcinoma may include vague palpable area of thickening or swelling in the breast, change in nipple shape, that is to say inverted nipple, dimpling of the skin, or shrinking breasts. Invasive lobular carcinoma is challenging to detect because of its slow growing and insinuating nature, which results in no clinically palpable mass formation and subtle mammographic and ultrasound findings. The incidence of invasive lobular carcinoma has increased over the past 2 decades and is attributed to increased use of hormone replacement therapy in postmenopausal women and to diagnostic advances. Invasive lobular carcinoma tends to occur in older women with a median age of 57 years, and it's more common in patients with lobular carcinoma in situ or atypical lobular hyperplasia. We can have a few words regarding the pathology so that we could have an idea why it is mammographically occult and usually it presents late. Invasive lobular carcinoma is characterized microscopically by malignant monomorphic cells that form loosely dispersed linear columns that invade the normal tissue and encircle the ducts. It encircles the ducts with preservation of the architecture. So usually there may be no obvious architectural distortion. Compare this behavior with that of invasive carcinoma of no special type, ductal 1, which more commonly present as a mass with vigorous desmoplastic response. Cells of invasive lobular carcinoma often preserves the architecture of the ducts, as we said, which limits the sensitivity of detection using mammography. Regarding the markers, it's characterized by loss of A cadherin, is a specific biomarker for invasive lobular carcinoma as opposed to invasive breast carcinoma, ductal 1, although 15% of invasive lobular carcinoma are positive for E cadherin. And the majority of invasive lobular carcinomas have the following receptor profile: estrogen receptor positive, progesterone receptor positive, and HER2 amplification negative. These could contribute to that despite late diagnosis and invasive nature of this tumor, it has better treatment outcomes in comparison to ductal carcinoma. Radiological features. Invasive lobular carcinoma is more often multicentric and bilateral, 10 to 15% are bilateral. Therefore, imaging evaluation of contralateral breast is crucial. There can be very subtle changes such as progressive shrinkage or enlargement or reduced compressibility of the involved breast. Imaging often underestimates the disease. Mammographic findings. The sensitivity of mammography for the detection of invasive lobular carcinoma reportedly ranges between 57 to 81%. Because of these limitations of mammography in detecting invasive lobular carcinoma, other modalities such as sonography and MR imaging are being used in evaluating clinically suspicious findings and known cancers to assess the extent of the disease. Invasive lobular carcinomas are more commonly seen on the craniocaudal compared to mediolateral oblique view. And this could be because of the unique diffuse growth pattern, which can be harder to distinguish in the angled MLO view due to magnification and tissue overlapping. Also, MLO view can obscure subtle signs of invasive lobular carcinoma, such as infiltrative masses, as the breast is often compressed more on this view, making it difficult to detect the lesion. So mammographic findings in order of frequency are speculated mass, lesion, most common, asymmetrical densities, opacities or architectural distortion, and less common microcalcifications. 16% of invasive lobular carcinoma are mammographically occult or reported as benign findings. We will go through some examples of mammographic features of cases of proven invasive ductal carcinoma after tissue diagnosis. The first case
invasive
is
lobular, yeah?
Sorry,
Invasive
invasive
lobular.
lobular.
Yes,
Invasive
lobular.
So the first case is 70 years age female presented with painless right breast lump. If anyone of the registrars of radiology are attending want to contribute, he or she is welcome. Otherwise, we can proceed. So we'll go ahead. This craniocaudal and MLO views of the right breast showing lobulated, almost higher density lesion located in the upper outer quadrant with faint and ill-defined speculations. No mammographically detectable calcifications on these views, and there is associated overlying skin retraction. More markable in the MLO view. Later on, we can see the sonographic correlation of this image, ultrasonography, I mean. Okay, the second case is for a 65 years old female, came for screening mammography and she has a family history of breast cancer in her first degree relative. These are the craniocaudal views of both breasts. It shows that there is a small mass with an irregular speculated margins in the right breast central upper part. And you can see the MLO correlation. There is also surrounding parenchymal distortion. It's highly suspicious by RAD5. In addition, there is a small mass with irregular margin seen in the upper outer quadrant of the left breast. This is the MLO. It shows also some areas of focal asymmetry in the right breast. So we can see also some foci of benign looking calcifications. And it's proved to be after sonogram and MRI and tissue diagnosis to be invasive lobular carcinoma, bilateral in the
The left
contralateral
side is
position.
single or multiple on the left?
It's single.
What about the posterior one? The superior larger lesion, there is another nodule posteriorly. Also dense for its size. Is
Yeah.
it intramammary lymph node, malignant intramammary lymph node, or another focus of lobular? It's suspicious for that. I don't know.
Mm-hmm.
Let us proceed.
Okay.
Have you seen it?
Yeah.
Yes.
I see.
Yes. Yeah.
Mm-hmm. It's parallel to the lower part
Pointed.
of the pectoralis.
Yeah. Pointed for them. Yes. If you have seen it.
Okay, I'll try to. Is this one?
Yes, yeah. It is too small to be dense like this. And I think when I zoom it, even it seems to be speculated. Okay, this is suspicious also.
Okay, but as per the case, it's not mentioned, but as you said, it's suspicious also, and then for its size.
Yeah.
How can I stop the pointer? I use it, but I couldn't stop it. Okay, see. Okay, thank you. The other case is 40 years old female, came for diagnostic mammography because she was complaining of left breast palpable mass on physical examination. So these are the craniocaudal and MLO views for her left breast. They showed multiple, almost higher density lesions. If you could see them, they are like 3 lesions parallel to each other in the upper outer quadrant of her breast. Posteriorly. And posterior in craniocaudal view, or posterior, yeah. So these are irregular in margins and causing surrounding parenchymal distortion. No internal calcification could be noted, or skin thickening or nipple retraction. And it has been proven, sorry, we will go for the other breast, for the magnification view, sorry. These are spot magnification views for the MLO and craniocaudal views, more visualization of the lesions. And this is a breast tomosynthesis for the mentioned lesions. You can see that. Almost 3 in parallel lines to each other. So ultrasound guided core needle biopsy is performed for all 3 left breast BI-RAD 4 lesions, and it revealed left breast 3 masses, invasive lobular carcinoma, classic type. Before left mastectomy, due to multifocal multicentric invasive lobular carcinoma of this case, the patient underwent bilateral breast MRI, and there was no suspicious lesion in the right breast. Breast ultrasound for the features of invasive lobular carcinoma. The most common sonographic appearance is that of heterogeneous hypoechoic mass with angular or ill-defined margins and posterior acoustic shadowing.
أمي مشت معاهم حرام.
An ill-defined heterogeneous infiltrating area of low echogenicity with disproportionate posterior shadowing is one of the sonographic characteristics of invasive lobular carcinoma. This is the first case, first example. We will see the ultrasound findings of this case. It showed لا لسه. It showed an ill-defined, deeply hypoechoic, heterogeneously hypoechoic lesion with, as we said, with disproportionate posterior acoustic shadowing. The mass has angular margins with surrounding echogenic desmoplastic reaction and architecture distortion. On color Doppler, the mass showed internal vascularity and new vascularity. And patient underwent mastectomy, and histopathology revealed cells with a moderately polymorphic plasmacytoid and features of polymorphic lobular carcinoma. And she underwent this mastectomy, and the operation revealed only 1 sentinel node. Another example with sonogram correlation, 65 years female, routine screening study, left breast. There is a small density high up in the left breast, new compared with her previous screening mammogram. Do you feel this lady is lucky?
If she's lobular, definitely she's not lucky.
Regarding the detection of this lesion.
It is fairly fatty breast, so
yeah, she's lucky because her breast is fatty. If a little bit dense, it's very difficult to detect this very small, subtle lesion.
Yes, agree.
So this is her sonogram. The lesion on the sonogram showed can see lobulated, deeply hypoechoic lesion with, as we said, disproportionate posterior acoustic shadowing, with surrounding desmoplastic reaction as well. The lesion is very small, but on biopsy turned out to be an infiltrating lobular carcinoma of the left breast. Previous screening, as we said, for this lady 2 years before was normal. Breast MRI role in invasive lobular carcinoma. Due to its propensity for multicentricity, breast MRI is usually recommended in many countries when histology of a lesion reveals invasive lobular carcinoma. This is a case of 55 years old female. Her screening mammogram showed architectural distortion reported as BIRA3. So these are T2 and T1 fat sat image of her right breast. It showed hypo intense lesion on T2 and hyperintense on fat sat T1. It's ill-defined lesion. The first image on the left of the screen is a T1 fat sat, then T1 post contrast, axial and sagittal images. It showed that there is mass-like enhancement of the noted lesion with lobulation, and there is another lesion or daughter lesion seen on the sagittal MRI. The surrounding area also showed enhancement with no clear fat plane between the lesion and the pectoral muscles on both contrast images. We will take few words about PET scan role in invasive lobular carcinoma. It shows that FDG PET has mild uptake and thus it's not very helpful in primary evaluation and assessing treatment response. Studies have shown that prostatic specific membrane antigen PET and fibroblast activation protein inhibitor PET give a better assessment of the disease status. We have this case as comparison. The image on the right side of the screen are for fibroblast activation protein inhibitors, and the image on the left side of the screen are for the FDG PET. The first example, example A, and the other example also are images of synchronous invasive lobular carcinoma. So the first case, 42 years old patient with multicentric primary lesion encircled in the image A and B, in the image on the right and left of the screen. And you can see that these circles, the lesion on the right side of the screen, the left side, the FDG beds are less than that noted after fibroblast activation protein inhibitors. More lesions detected with satellite lesions. Those are in the circle. Regarding the axillary lymph nodes, more notable on the second scan. Even it detects distant inferior jugular lymph nodes, the dashed arrow. Another example for 53 years old patient showing no significant uptake on FDG PET, but synchronous bilateral lesions, arrows, as you could see, on FABI PET, which also identified pathologic lymph nodes, that one in the circle. The image is from Journal of Nuclear Medicine. So in conclusion, invasive lobular carcinoma is the second most common type of invasive breast cancer and typically manifests with subtle clinical and imaging findings, making diagnosis a challenge. The most common imaging manifestations of invasive lobular carcinoma include a mass with speculated or indistinct margins at mammography and hypoechoic irregular mass with posterior shadowing at ultrasound. The role of MRI in evaluation of the extent of invasive lobular carcinoma includes depicting tumor size, and the presence of multifocal, multicentric, or bilateral disease. And despite the difficulties of mammographic diagnosis and the propensity for multiplicity and bilaterality, the overall survival rate for patients with invasive lobular carcinoma of a given size and stage is believed to be slightly higher than for patients with invasive ductal carcinoma. Due to the diffuse invasive nature of this tumor, positive resection margins can be common. And these are the references. Thank you so
Thank you
much.
very much. Amazing lecture and very nice presentation. Thank you very much. Lobular
Thank you.
carcinoma.
Excellent, Abia. Excellent, Abia.
Always lobular
Excellent.
is
Thank you.
very
Thank you so
challenging.
much, Dr.
I
Rabab.
am so impressed by your presentation. So confident.
Yes.
Thank you so much, Dr. Rabab. والله يعني
Precise and to the point.
Informative.
Yeah, informative. Yeah.
Yes.
Those our juniors. You see, this is one of our juniors. First presentation.
MashaAllah, tabarakallah.
ما
This
شاء
is
الله
her
ما
first
شاء الله.
presentation. Yeah, mashallah. Yeah.
You should be proud of them, Dr. Rabab.
Yeah, so proud. No, يعني شعوري لا يوصف.
ما شاء الله
والله
زي
proud,
شعور
شكرا
proud,
دكتور
لكم جزيلا
proud.
رباب
جزاكم
I'm
الله
الإجابة.
خير على
proud,
التشجيع يعني احنا خجلانين
proud
على قول
of all
دكتور
of
ردينا
you.
احنا خجلانين نقدم بعدكم اصلا يعني بعد العلم اللي انتم قدمتوه فربنا يجزيكم خير ان
ما
شاء
شاء
الله.
الله تبارك الله ما شاء الله تبارك الله. أساسا ما يعني ما شاء الله ما في وصف الكلام يعني to the point و evidence based very nice cases ما شاء الله تبارك الله. All
I'm
the
so
best.
proud of
تسلم
all of
جزاكم
you.
الله خير.
كلكم اسمعي يا دكتورة نادية كلهم طلبتي زي ما
ما
قالت
شاء
دكتورة
الله ما
فاطمة
شاء الله.
البيت.
You are lucky.
الحمد لله.
and they are your followers. ما هم they will take up the challenge back.
Yes, yes, definitely.
What I wanted to happen just to what you said in pathology especially, it was quite interesting, all of it. And I know that lobular carcinoma is a challenge for you in radiology as well as for us in the lab, because it's not always so easy to differentiate. There is a percentage of cases where you have to do cathetering to make sure that it is lobular and not a mixed lobular in ductal. The thing about when you explained how it goes periductal, in invasive, we have just a sheet of cells that destroys everything in front of it. And we describe the cells of lobular as discohesive cells. So the cells have nothing to do with the neighbor. They might look monotonous, but they just spread and take. But in ductal, it just destroys everything. It destroys blood vessels, nerves. It destroys everything. The funny thing in these cohesive cells, زي بتسحبوا كده بطريقة more silent and less destructive. عشان كده نحن بنلقى الفيتشر بتاع periductal invasion. فاللي هو نحن بنلقى الدكت قاعدة زي ما هي النورمال دكت وما زي الدكتال invasive ductal carcinoma ما ممكن تجي على الدكت ما تعمل لها destruction لو قاعدة في الطريق. لكن اللوبيولار بتمشي حولها. And this is the peculiar feature that we see. That you see periductal invasion. You see a duct that is normal قاعدة وما destroyed قاعدة في نص التيومر. Did you understand it as such?
ايوه بس شكرا لك على التوضيح والمداخلة. شكرا جزيلا.
لا
أيوة.
but انت كنت فاهماها كده. كنت فاهماها زي الشرح بتاعي.
أنا يعني حسب اللي جيته إن هي أيوة
معلش
الانفيزيف
عيدي تاني
لوبيولار
يا دكتورة
كارسينوما.
عيدي لنا
يعني
الكلام ده تاني.
في الانفيسيف ductal carcinoma, when it starts spreading and infiltrating, it will destroy whatever it is in its path. It will destroy a duct, it will destroy a blood vessel, everything is destroyed. And it's invaded. لكن اللوبيولار بيعمل حركة اللي هي غريبة اللي هو بيمشي حول الدكت
it doesn't destroy it, it goes all around it, and the duct remains in the middle of the tumor وقاعدة زي ما هي normal. لما يعمل
زي الليمفوما.
infiltration أيوة a bit بيعمل زي الليمفوما. There are discohesive cells that go into the tissue and infiltrate وما في واحدة عارفة أخوتها بتعمل في شنو، لكن في نفس الوقت it leaves this duct
بيحترموا
intact.
الضغط جدا.
بيحترموا الضغط ما كلهم، لكن بتلقى ضغط قاعد. This is the sign that this نفس الشيء اللي هم بيعملوا.
نادية عندها اسم كاركترستيك صح؟ السبريد بتاع ده اي عندها كاركترستيك نيم انديان انك ولا something حاجة كده.
ايوه الثانية اللي هي الانديان فايل اللي هي
انديان فايل اللي هو
برضه
بتكون زي اللي هي بتكون زي سنجل لاير سبريد صح؟
اللي هي سنجل لاير، السيلز سنجل لاير ماشيين ورا بعض وقاعدين between the fibers constituent background fibrous tissue، لكن it's not destroying it، لكن it's infiltrating between them عشان كده
الإفكت بتاعهم في التيشو is minimal. That is why it doesn't appear. That is why it doesn't appear. عشان كده
and that's why it doesn't form a lump.
Yeah, doesn't form a lump لأنها بتمشي مع التيشو طوالي، يعني spreading
في
مع
الصورة
التيشو.
بتاعتك يا عبير ظاهر.
بتمشي مع التيشو spreading along the tissue، وبالتالي يعني اسمه شنو ده في الماموجرافي بالتيشو بلينز، بالتالي في الماموجرافي بتظهر لنا as added density.
ايوه
added density
not
only.
as a mass.
خلاص not as a
كأنها
mass.
بريست تيشو.
كأنها بريست تيشو، عشان كده it is difficult. وفي نفس الوقت clinically تحسيها كثيكنس
not as a mass.
thickening of the tissue not as a mass. دي الماجوريتي أو يعني كثير منها. That is why it is difficult. That is why it is difficult. But when it is spread in the different way, that it can represent a mass or become palpable.
Yeah, in both your presentations, Abir Wala, you have remember Wala when in your earlier picture of invasive أنا قلت لك الصورة صغيرة أنا ما قادرة أشوف لأنه كان في بالجنب كان شكل زي الإنديان فايل.
أيوة قلت لك نادية I thought it is lobular. I thought it is lobular. I need to see
higher power
to comment on. I thought this is lobular but you said it is ductal.
يا دكتورة نادية زي الحالات دي الباثولوجيست لما يتكلموا معانا في الام دي تي ويقولوا كلامهم ده عادة السيرجونز بيقولوا خلاص نعمل اكسجين.
اوكي.
وفعلا بعد تطلع تخيلي بتطلع ما بيناين. يعني عندي حالات كثيرة إن شاء الله كده يعني في ويبينار كده لقدام أقدم معاكي باثولوجي راديولوجي كورليشن وديسكورليشن. فعندي يعني عندهم حالات ديسكورليتد كثيرة بيقوم الباثولوجيست في الام دي تي بيقول والله أنا شايف نفس كلامك ده، أنا شايف حاجة ما مظبوطة في السلايد مع إنه بيناين تشينج. فبقوم السيرجون بيقول خلاص ما دام هي بيناين وشبيهة بالبيناين خلاص نعمل وايد لوكال اكسجين او مش وايد لوكال يعني اكسجين. فبيعملوا اكسجين بتطلع لوبيولار ولا بتطلع فيه يعني مالجنسي.
اوكي.
فهي فعلا هسه الصورة دي ما كانت ظريفة خالص.
دي زي الهاي ريسك ليجن.
ايوه ما كانت ظريفة. أنا برضو ما اقتنعت بالبيناين تشينج. هي الصورة من راديوغرافيكس لكن ما مقنعة إنها بيناين.
راديولوجيكالي ولا باثولوجيكالي؟
طلعت فيسيولوجيكال. لا الصورة بتاعتي
اللي ما مقنع بالنسبة لك كان الراديولوجي ولا الباثولوجي؟
الراديولوجي ذاته ما مقنع لأنها irregular.
بس أيوة بس كان في حالة أنا كنت منتظرة إنه تكومنت at the end و I forget it. كنت قلت دكتور رباب she's going to comment on. بس بصراحة الأوفرول presentation was so impressive فما قدرت أنا I forget الماينر things. لكن
الحالات كانت كثيرة. البرزنتيشن طويل ذاته يا رباب.
أيوة لا لكن ما كان ما شعرنا به. It was يعني very enjoyable. لكن
really,
I do agree. Both of you والله. I do agree with you. Some of the cases okay, even are benign, but radiologically are not typical benign, are not typical.
وحتى
And I've
الباثولوجيست بيقول شاف حاجة ما تيبيكال. حتى
يلا
الباثولوجيست يعني الدكتورة نادية قالت لك أنا
for us
شفتها في البريفرال حاجة ما ظريفة فيها
it's
إنديان.
okay. يلا for
أيوة.
me in my practice unless the probably benign first time I have seen a lesion, unless it is very typical like cyst, simple cyst with full criteria as Amal described of simple cyst, imperceptible wall, regular shape, okay, posterior enhancement, and echoic, this is simple cyst, or typical fibroadenoma, flat, oval, but not bulging anterior posteriorly, very flat, circumscribed with pseudocapsule, and the echogenicity is not very deeply hypoechoic. It is iso to slightly hypoechoic. I'm not going to call it that. I will call it BIRAT 2, the simple cyst. This I will call it BIRAT 3, probably benign. Or see complicated cyst, typical inflammatory cyst, I'll call it BIRAT 3. Or cyst with fine internal echoes, I will call it BIRAT 3. Otherwise, I will go for BIRAT 4A. I will push toward BIRAT 4A and I will leave it for the clinicians either to upgrade or downgrade or to follow the patient according to him or to recommend the biopsy. I'll put it.
Recommend biopsy.
I will put it BIRAT 4 and recommend biopsy. But BIRAT 4A, not all BIRAT 4A, the clinician go
will
for
biopsy.
Will biopsy. Some of BIRAT 4A, they prefer to follow them. Some they will go for biopsy. But unless it is very typical, usually, and especially lactational adenoma, it is usually mimickers. It is a usual mimickers of breast cancer. Okay, and even fibroadenoma, if it is the first time presented during pregnancy or lactation, it is a mimickers of cancer because of hormonal changes, associated infections, associated, it became either infected or complex fibroadenoma. And complex fibroadenoma, it is BIRAT 4. It is not a BIRAT 3. I will not report it as BIRAT 3. But that is why, yes, I agree with you. When you comment on that case, yes, I do remember it. Yeah.
تمام. يا ولاء.
أيوة.
انت قلتي نعمل لكشر مع بعض. This is a special interest برضو بتاع أروى was interested in something like that.
Yes.
أيوة.
Yeah. No problem. We can combine. Also, I have interest and I have report once before.
إن شاء الله
like
نعمل
that. We can
أنا كنت عايزة أعمل معاها والله وجهزته، لكن حسيت إنه أنا عايزة أخليها تقدم مباراها في كسيشن، بعد ذاك لقدام في الMDT سيشنز مع بعض ممكن نعمل يعني لكشر زي لكاشيرنا الزمان اللي هي كان بيكون فيها multi disciplinary.
أيوة. I think it is better than in the symposium. كان يكون عشان تدي وقت للدسكشن أكثر.
والفائدة فيها أكبر.
Exactly. We can. Yeah. Exactly. We can make it. We can make it as well. Scientific webinar. كده اللي قدام إن شاء الله.
إن شاء الله. تمام. يلا. شكرا.
بإذن الله. شكرا يا دكتورة نادية.
Both of you.
Let us thank you, Nadia. Thank you very much. We can proceed. We can proceed. Who's the next?
هبة موجود. مين معنا؟ إسراء. Who is presenting? إسراء صح؟
Yes, إسراء.
أنا حدي فرصة للمودريترز اللي معاي لأنهم متقسمين يعني.
أيوة إسراء is the one who start to present.
إذا ما
شكرا
موجودة أو أيوة
موجودة
يلا
موجودة.
اتفضلي يا إسراء.
شكرا جزيلا دكتورة عبير. next دكتورة رباب تقريبا المفروض تكوني next لأنه دكتورة مهيرة ما موجودة.
لا دكتورة مهيرة عن دكتورة رحاب.
دكتورة مهيرة موجودة.
She's not here. Dr. Rehab is not here. For me, my presentation, I couldn't prepare it well because I have social issue, and I'm going to present it for you later. Stay tuned. After October. Me and Dr. Nauras. Dr. Nauras also, she has technical issue. She couldn't present. She's going to present for you maybe on November, and I will present on December, the 2 sessions. But Meher is ready and Rehab is ready, but I don't know where are they. Both are ready.
هم تقريبا ما online يا دكتورة، ما موجودين.
Let us call them. Let me call them.
Okay.
السلام عليكم. الوقت وقت صلاة المغرب، ممكن الناس تكون بتصلي، لازم يعمل لهم كول بيرسونالي.
أيوة صح، إحنا برضو عندنا.
ترتيل did you call دكتورة رحاب؟
أنا حصلي العصر في المسافة دي وأجيكم إن شاء الله.
It's okay. ترتيل.
اوكي، ولا
did you
كيفك؟
call؟
شباب طيبة.
أهلا وسهلا، كيف الأخبار؟
تمام. سمية معك؟
كيف يا سمية؟ تمام؟
تمام الحمد لله.
الله يسلمك وتسلمي، الله يبارك.
Are you there
أتكلم معك
ترتيل؟
بعدين.
ترتيل are you there؟ سمية كيفك؟ تمام؟
تمام والله الحمد لله. كيفك انت يا بوس؟
الله يكرمك يا رب.
الله يحسنك. الله
ترتيل
يبارك.
maybe she left for prayer because I asked her to call Dr. Rehab because she's in Sudan and Rehab in Sudan. But let me call them and I'll come back. Let us go to pray 15 minutes, okay, for prayer and come back.
اوكي.
إذا الناس موجودة نبدأ. مهيرة موجودة؟
يا ولاد دكتورة رباب قالت 15 minutes.
أوكي معلش لأنه ما مكتوبة في الشاشة، سوري.
هي بس بعد ما انت مشيتي للصلاة قالت خلاص انت الناس 15 minutes يصلوا ويرجعوا كم وقتهم.
خلاص تمام.
Meher is here. I think Meher is ready. Wala, you can share for Meher her presentation. Let her start and we'll try with Dr. Rahab at the end. I asked Dr. Rahab to get in and we'll try. She couldn't send her presentation. There is technical problem, but we'll try to share from her side. We hope it will succeed.
Okay, then we will stay with Dr. Mohira Ishaq,
Yes.
MD of Radiology, SMSB, Head of Radiology at التميز Emergency Hospital, Khartoum, for imaging of axilla presentation. Dr. Mohira, please proceed.
Dr. Awala should share for her the presentation. Wala, are you there?
أيوة.
Share دكتورة مهيرة presentation.
هي عايزة أنا أشير لها ولا تشير؟
Yes, شيري لها.
تمام.
مش كده يا مهيرة؟ I think
خليني بس أخليه فول
yeah,
سكرين.
شيري لها. شيري لها.
تمام. بس قول لنا نيكست يا مهيرة لما تكوني عاوزة تغيري. إسراء لو سمحتي قدمي مهيرة. إسراء السلام عليكم.
امتى دكتورة ولا؟
يلا. أوكي. قدمتيها؟ قدمي مهيرة عشان تبدأ البرزنتيشن حقها.
دكتورة مهيرة MD of Radiology SMSB, Head of Radiology at التميز Emergency Hospital, Khartoum, for imaging of axilla presentation. Proceed, please.
Over to you دكتورة مهيرة.
Can you hear me? Can you hear me?
دكتورة مهيرة, are you ready?
Yes.
Yes, you can start now. دكتورة مهيرة, her first time presentation, the same first experience.
Well done.
You are welcome,
Well done,
دكتورة
دكتورة مهيرة.
مهيرة. Yes.
Hi. I'm going to present axillary images.
الصوت يا مهيرة.
شكلك فاتحة جهازين يا مهيرة.
Hi.
في صدى, لما يكون مفتوح جهازين بيعمل صدى.
الجهاز الثاني أعمل ميوت وأقفل الميكروفون الاثنين.
كده سامعيني كويس؟
أيوة بس علي الصوت. سامعينك لكن علي الصوت شوية. الصوت واطي.
تمام. Good evening. My name is Dr. Muhaira, MD radiologist, Al-Ubay Teaching Hospital, Sudan. I'm going to present imaging of the axilla. Next. I'm going to start with the basic anatomy of the axilla. The axilla is composed of axillary artery, vein, brachial plexus, lymph nodes, fat, accessory breast tissue in some individuals, skin, and subcutaneous skin. Next. Regarding the anatomic boundaries of the axillary region, superiorly we find clavicle, scapula, and hair strip. Posteriorly, scapula, subscapularis muscle, teres minor, major muscle. Anteriorly, pectoralis major and minor muscle. Medially, teres fortis and serratus anterior muscle. And laterally, there is bicipital groups with bicipital and coracobrachialis muscle. Next. Regarding lymph nodes in the axillary region. If we take a surgical division, we have 3 groups of lymph nodes. Our landmark is the pectoralis minor muscle. Lateral to the pectoralis minor muscle, there is group 1 lymph node. Posterior to pectoralis minor, there is level 2, and medial to pectoralis minor, level 3. Now, in this MRI, we can clearly see the 3 groups of lymph nodes. Laterally, level 1, posterior to pectoralis minor, level 2, and medial to pectoralis minor, level 3. Yes. So when we are going to talk about imaging of axillary lesion, based on the clinical presentation, medical history, risk factors, and patient age, imaging most often entail a combination of different imaging modalities, followed by surgical consultation or follow-up. Starting with axillary ultrasound, axillary ultrasound should be performed either with high frequency setting, which is routinely used, or low frequency setting in case of obese patient or patient with dominant axillary region. The patient should lie in supine oblique position with her hand above her head and her arm abducted and externally rotated. All findings should be documented in orthogonal planes with and without calibers, and the lesion with the largest diameter should be recorded. So, if the initial imaging with axillary ultrasound show any suspicious finding, percutaneous procedures with fine needle aspiration or core biopsy may be performed. Regarding mammography, if there is a personal history of breast cancer or clinical suspicion of axillary tail breast carcinoma or metastatic adenopathy from breast primary, in all of these cases, mammography is used to provide a global assessment of the bilateral breast and to identify any suspicious breast findings such as microcalcification associated with alpha-1. Regarding MRI breast, if mammography or ultrasound is negative for primary breast malignancy and the patient has a suspicious axillary lymph node, in this case, we use MRI breast to identify any underlying breast primary which is missed in mammography or in ultrasound. So, MRI breast is used for identify of any primary breast cancer. It's also used to characterization of axillary mass by determine of involvement of adjacent vessels, chest wall, or axillary structure. CT chest, abdomen, and pelvis. CT chest, abdomen, and pelvis is useful in cases of lymphadenopathy, in cases if you want to assess for any local bone involvement, pulmonary involvement, or any intrathoracic or abdominal or pelvic involvement. Now we will move to differential diagnosis of axillary finding. Differential diagnosis includes benign and malignant lesions, either from skin and subcutaneous tissue, accessory breast tissue, lymph node, or lymph node calcification, postoperative, and neoplastic. Either benign in case of skin subcutaneous tissue, benign lesion like facial cyst, malignant like skin metastasis. In case of accessory breast tissue, we can find benign lesions like fibroadenoma, malignant like breast cancer. In case of lymph node enlargement, it could be reactive due to granuloma or like sarcoidosis, and it could be malignant due to primary or metastatic diseases. Lymph node calcifications could be due to granulomatous diseases, gold therapy in case of rheumatoid arthritis, and it could be malignant due to ductal carcinoma in situ or metastatic disease. In case of both operative findings, it could be benign like skin thickening or collection, and it could be due to primary or metastatic recurrence. Neoplasm, we can find benign neoplasm in axillary lesion like schwannoma, and malignant from breast axillary carcinoma. So starting with the skin lesion, like in these two images, we have in this mammography tangential view a skin lesion in the axillary area, which have a hypoechoic epigenicity in the ultrasound. These findings are highly suggestive of suspicious or epidermal inclusion. Regarding congenital developmental anomaly or accessory breast tissue, these are a rare finding in 2 to 6% of women, most commonly in axillary lesion, but can occur anywhere in the midline from the axilla to the inguinal region. It can be appreciated in mammography, ultrasound, or MRI. It could be benign, like cyst, fibroadenoma, or malignant like breast carcinoma. In this case, this patient has an area of focal asymmetry in her axilla with similar density of her fibrogranular breast tissue. In her complementary ultrasound, we find a prominence of fibrogranular epigenicity breast tissue in her axilla, surrounding a small hypoechoic lesion, which was proved to be fibroadenoma after birth. So in this case, there is accessory breast tissue with fibroadenoma.
Interesting, Mohera.
Thank you. Regarding lymph nodes, which are the most common finding, I think, in routine practice, ultrasound provide best primary assessment for axillary lymph nodes. In case of benign appearing axillary lymph node, it will be oval or lobulated in shape like this lymph node, smooth, well-defined, with thin, slightly hypoechoic cortex that shows 3 millimeter or less thickness. There will be hilar vascularity in case of benign lymph node. Characteristic of malignant lymph node is round or irregular shape, hilar effacement or non-hilar blood flow, increase concentric or focal cortical thickness. Like in this case, we can see an enlarged lymph node with effacement of the hilar. We cannot see any hilar, and we can see peripheral non-hilar vascularity, which goes with malignant or suspicious lymph node. Mammography. In mammography, increased size or density of lymph nodes raises possibility of malignancy. In this mammography, we can see multiple axillary lymph nodes. The largest one show cortical bulging with areas of calcification. Try to zoom. Can you zoom? Hello.
ما أظن بنقدر إلا تعملي لها adjustment، يعني تطلعي من البرزنتيشن وتعملي لها زوم برا. لكن الكلاسيفيكيشن ظاهر، أنا شايفاه غايته.
تمام. دي عين الخبير يا دكتور.
ممكن أعمل لك عليه
There is calcification, yes.
أيوة.
Yeah, within the lymph node, yes, we can see calcification, micro calcification.
Yes.
Yeah.
The complementary ultrasound show cortical bulging with filar effacement and echogenic lines that represent areas of microcalcification in the wound. All these findings goes with suspicious for malignancy. Post-operative axilla. Following axillary surgery, an array of findings can be seen in the axilla. The most common finding include skin and trabecular thickening. Like in this case, there's clear skin, trabecular thickening with a sexual distortion. We can also see a fluid collection or lymphocyte, fat necrosis, and recurrence. Benign neoplasms. There are several rare benign neoplasms that can occur in the axilla, which can mimic breast cancer in the axillary scale of substance. In this case, we can see a small rounded lesion in the axilla that show mainly hypoechoic genicity in ultrasound with no clear vascularity. It was proven by biopsy to be granular cell tumor. At the end, we can see extra-axillary lesions that may originate from nerve, muscle, or any of axillary content. Like in this case, we can see a complex axillary lesion, mainly cystic, with minimal peripheral vascularity. In the MRI, in the sphere, is mainly hyperintense, located in the latissimus dorsi muscle. In both contrast, it shows areas of peripheral and central enhancement. Thank you. This is the last slide. Thank you for listening. Any questions?
Very good, very good. Amazing presentation.
أقري الكلام الكاتباه وأقري الكلام الكاتباه في البتاع ده البلد الحنين. البلد الحنين سميته يمه ويابا.
أقريتي يا أبو طارق.
ليش أقريتي ما كاتباها؟
البلد الحنين سميته يمه ويابا، بين العالمين عزة وجمال ومهابة. الحزن القديم تمطر تزيل سحابة، لا أطفال حزانة لا نازحين غلابة.
اللهم امين. يا سلام عليك، يا سلام والله كلام يعني بصراحه لامس القلب. ما قصرتي. excellent presentation مهيرة. يعني ما اعرف اقول لك شنو بجد. I am so impressed. It is the first time but it is an excellent experience. Thank you very much. We hope to see you in the coming symposium. Okay, don't miss any of the coming symposium.
I have very good article about axilla. We can let the new registrars to present journal, to make journal clubs in our symposium even. So they can have
Good.
section in the symposium for journal. We give them the most recent articles in a very sensitive areas. They can present a very good because she did very well. It is similar,
Yeah.
not far away from the recent things in the axilla. So they can do that, and they will have a very good experience and insight about the updates in everything.
Yeah.
So
Yeah.
we can share the registrars the recent articles. What do you think?
Thank you so much for that suggestion. Thank you.
Yeah. Good suggestion. Excellent suggestion. I do agree with you.
Because we are doing this in our department, we have every first of the month journal club presented by registrars. So they are doing very well job, and they will show us what is new without digging in the internet in
Yeah.
a very
Good.
good, concise way. So 30 minutes only, not far
Nice.
much.
Nice. This group will try to give them topics and to present for us session accordingly. It depends every 2 months, every 3 months.
Yes, and we
I
can
think it
mentor
will
them
be
in the
difficult.
beginning.
Yeah, it will be difficult every month, but we can make it. We
In
can
every
arrange.
symposium, in every
Yeah, that is.
symposium, we can
I'm going
have,
to say. Yeah, I'm going to say
yeah,
the same. I'm going
yes.
to say in every symposium we can make one day like that and the other day for the remain of the symposium topic.
Not one, even
It is
30
the
minutes
same
only is enough. Within the
for
symposium
everyone.
itself, we can, yes,
For
we can give
everyone.
them like chance to present
Yeah,
a journal notes,
good,
inshallah.
good, inshallah. No problem. We'll arrange for that.
Inshallah.
Okay, I think Rahab Al-Yamani now available. Let us give
أنا
her
ممكن
chance
أعمل
to try
لها
from her
presentation.
side. Did you receive her presentation?
أيوة
She
رسلته
couldn't.
لي، فأنا
وصلت؟
ممكن
Good,
أيوة
good,
أيوة
good. If, good.
خليني بس أنزله وأعمل
She thought
له
that
share. هي
not
موجودة
all
لأنها قالت
people.
سايقة.
Yeah, no, now she's available. I have seen her.
Okay.
I have seen her. Are you available, Rahab? I have seen her name.
يا بص
يلا هذا البريزنت
بس أبركنش إذا ليه لا بركن في
كويس.
حتة بس
ما في
بركن
مشكلة، البعديكي منو ممكن يقدم لو فاضي، ما في
I
مشكلة، ما نورش.
I think no remaining. Do you have anyone more?
ممكن نعمل discussion على بال ما تبركن في
We
حتة
can
سيف.
discuss. Yeah, we can discuss. We can make discussion for the latest presentations or even the whole presentation. If anyone have questions or comments, you can start discussion and wait for her. And you can check the schedule, Dr. Awala, who is next, apart from me, because you know that
Okay.
I have social issue. I cannot present today, but I
Let
promise
me
I
just
will
check.
present my topic on December. Dr. Nauras is going to present it on November along with Dr. Rodina, because Dr. Rodina yesterday, her presentation was excellent. She well prepared, but the technical issue affect her mood and her presentation, and we promise her to present it again in a relaxed situations or conditions. So on November, Dr. Rodina and Dr. Nauras, they will continue this symposium. And for me, I'm going to present after them on December, inshallah. I'll present for you my topic, Beyond Virus, Non-Mass Ultrasound Findings.
Inshallah.
So check for the schedule if there is anyone
The
remain.
schedule only Rihab, no Zainab and Sarah Isam, they are not available. Yes.
Zainab presented already. Sarah
Sorry.
Isam, no, Sarah Isam,
Maybe when I
she
was
couldn't.
away.
Sarah Isam, she couldn't cope. She has
Okay.
work issue. And she could not
Okay.
arrange her work. She's still working, and she could not arrange it. She has
So I
difficulty.
don't think anyone who is left, only Rehab and finishing.
Okay, so I told Rahab we can wait for you at the end to adjust your technical problem. Okay, after that, I think Dr. Anas supposed to be here to make the closing remarks of this symposium. But now you
أيوة.
can start discussion. Hopefully, Dr. Rahiba now is here, Dr. Fatma Baqi, Magdalene, along with Dr. Nadia, Sanabil, Sumaya, Yusra, Zainab, Amal.
Welcome.
Good,
Everybody
good.
welcome.
Yeah, others without name. We have good number. So you can, if anybody you would like to initiate discussion regarding the topics already presented.
دكتورة نادية حضور مشرف ما شاء الله تبارك الله. From the
Sure.
start to the end. Always,
Thank
as
you.
usual.
I really enjoyed. Thank you very much, all of you.
Thank you for your time.
Thank you for
and,
your efforts.
and your insights.
الله يرجعنا للشغل.
إن شاء الله يا رب.
Dr.
إن شاء الله
Nadia
إن شاء الله.
always supporting our
شاء الله.
sessions. Thank you very much.
عفوا والله I
يعني
enjoyed so much. It's really a change. And
yeah,
you work very nicely together. This is so wonderful.
yeah,
Presentations
thank you
are very important. It is not just the dissemination of knowledge and interaction. It is knowing how to find the right things to say. And I love it today because you made it short to the point, each in your presentations.
Yes, yes, yes. Really to the point. Really informative.
MashaAllah.
And also, yeah, we enjoy your presence with us always. We miss you
شكرا لكم
when you
كتر
are not
خيركم.
here. We really yesterday we missed you. So
أيوة
yesterday
I couldn't manage. Alhamdulillah, my brother is doing much better. He's going now for a 3-week rehab. لكن امبارح مشيت له يعني المواصلات بتاخد وقت شوية. الحمد لله كويس.
الحمد لله ذلك الفضل من الله ربنا يطمنك عليه. Yesterday also I was busy. I could not يعني fully present. I could not attend it all of the sessions fully. I just
لكن
part of the
مسجل إن شاء
session.
الله نشوفه.
بإذن الله. Because of the social issues, we came to Makkah and we have a lot of visitors from
بختكم
relatives.
ما شاء الله.
They came
والله we
to
are jealous يا رباب. ما شاء
أي
الله
والله.
تبارك الله. ما شاء
الله
الله.
يديك العافية. والله إلى الآن أولاد عمي معنا عرفتي، لكن هو مرة في البريك بمشي
انتي
أتونس
والله you are
معاهم.
making very hard effort ما شاء الله عليك تبارك الله.
عارفة في البريك لما تدونا بريك ده أنا بمشي أقعد معاهم لما تقولوا خلاص بجيكم مراجعة.
ما شاء الله تبارك
لكن
الله.
ربابة اللمة طبعا كويسة عشان you have to get over شفت الناس يعني بعد البكا ده مهمة شديد.
أكيد.
This is دي الحاجة اللي احنا بنعملها في السودان في الأيام الأوائل، لكن حسي هنا صعبة. فالحمد
أكيد
لله
أكيد.
اتلميتوا عشان بعد ده you take the next step of
بتعمل
healing.
ريليف، بتعمل a lot of relief. عشان كده
مع
أنا
إنه ما
I
بتنسي
could not
ما بتنسي حاجة أصلا ما بتروح. أنا I lost my father in 82. Very early. I didn't even graduate from college. فدي كانت حكاية صعبة خلاص.
سبحان الله.
وما بتتنسي يعني from experience دي حاجة ما بتتنسي.
شور والله.
الحمد لله.
أيوة. لا الحمد لله. ده قدر الله. قدر الله.
الحمد
لكن
لله
طبعا
الحمد لله.
زمان هو كان بيعيش معايا سيمبوزيوم فيه ويعرف ولا ويعرف نادية ويعرف مين. كل
سبحان الله.
المشاركين وعملنا شنو وصلنا وين والبرزنتيشن فضل شنو ومرات يحضر معاي.
الحمد
سبحان
لله
الله.
الحمد لله.
الحمد لله.
ربنا يرحمه.
الحمد لله. ربنا يرحمه ويتقبل قبول حسن
ربنا
ويرحمهم
يرحمه.
جميعا، يرحم جميع
أيوة
من فقدناهم.
ربنا يرحمه ويغفر له إن
أيوة
شاء الله
والله.
ويسكن فسيح جناته ويصبركم
آمين
أحسن عزاكم يا رب.
آمين
هم السابقون ونحن
آمين.
اللاحقون، ربنا يجمعنا بهم في أعلى عليين يا رب.
أيوة إن شاء
اللهم
الله إن
آمين
شاء الله.
اللهم آمين. عشان كده المرة دي
يا
اعتذرت
البركة
منكم، ما
ذريته إن شاء
قدرت
الله.
أحضر، ما قدرت ما
ما
لحقت
في مشكلة،
أحضر لكم.
لا
نتعوض
لا
إن شاء
ما
الله.
في مشكلة يا دكتورة رب،
حضورك
ما
براو
تعب. أي
بالدنيا،
والله
انت ما شاء الله
ما
يعني
قصرتي مننا والله يا دكتورة رباب،
تبارك
الله
الله.
يجزيك عندنا كل خير. ما
في
آمين
الام دي بي
جميعا.
قدمتي
عندنا ده
كتير ما شاء
حقنا.
الله.
أيوة أيوة والله.
لا إن شاء الله ما موضوعين معاكم هنا، ده بقدم لكم في ديسمبر بإذن الله، بإذن الله كده أحد لو ربنا أحيانا جميعا.
إن شاء الله بإذن الله.
بإذن
السلام
الله.
عليكم.
وعليكم
وعليكم
السلام.
السلام.
رحاب موجودة الحمد لله.
تمام. Are you ready رحاب؟
السلام عليكم. معلش
عليكم
يا جماعة
السلام.
I'm
لا لا
ready
ما في
إن شاء الله.
مشكلة الحمد لله.
طيب introduce رحاب let us start.
Dr. Rehab Osman Abdulrahman, consultant radiologist, expert in diagnostic radiology and reporting standards, presenting breast density assessment and reporting standards. Dr. Rehab, please proceed.
Okay. بسم الله والصلاة والسلام على رسول الله. السلام عليكم ورحمة الله. First of all, thank you for being patient for my circumstance.
You are more than
Starting
welcome.
now, I know this is like a repetition and maybe they are so basic and we all passing through it most of the time. ولكن الذكرى تنفع المؤمنين إن شاء الله. So next please. Firstly, considering the breast density, we have to know basically the anatomy of the breast. The breast is composed of fibroglandular and fatty tissue. They are mainly the cause of the appearances that we see on imaging. The fibroglandular tissue, the base of it is the terminal duct lobular unit. When we go further, we got terminal duct tubules, which the arsini, they're connected together and they're connected into interlobular terminal duct. This is called the lobule. Together with extralobular terminal duct is called the terminal duct lobular unit. And this is the mainstay of the base of the fibroglandular tissue. These are connected together and go for the main lactiferous duct. Collectively, many terminal duct lobular units, they form the appearance of the breast, as we know. So next, please. Just is it clear for you that here?
Yes, it is. Proceed.
Okay. So what's breast density? It refers to the amount of fibroglandular tissue in the breast relative to fat. It varies in the man individual, considering the age and when over time, and from area, even within the breast. So the distribution of them comes with what's called breast density. Next, please. The density evaluation, we know our images are ultrasound, mammography, and MRI. MRI. Yeah, can we go just starting with ultrasound? As we see here, this is the shape of the breast. Look here, there the skin, the fat, the nipple, and the fibroglandular tissue. When we get the ultrasound, we put it the surface of the breast. We take it like that, starting from the skin and then subcutaneous tissue, fibroglandular tissue, and the retromemory area. So it's collectively called three compartments, and they differ according to the breast components. So next. As we see here, this is illustration of the main anatomy of the breast. Here we got it's the skin and the subcutaneous fat. This is called the pre-mammary zone. It's bounded with the superficial and deep fascia, included centrally within fibroglandular tissue. And here is the retromammary zone, which is composed of fat also, which is called retromammary fat. And posteriorly, we got the pectoral muscles, and then ribs and the lungs. Here, more deeper, we go to the ducts, the main ducts and the side ductules, and these are the mainstay of the terminal duct. As we illustrate there, the terminal duct composed like so. Next. So what we got on ultrasound density of the breast. According to the distribution, when we got mostly fatty, it appears like hypoechoic, and this is called homogeneous ecotexture fat. When it's thick fibroglandular and it appears uniformly white, like bright, this is called homogeneous ecotexture fibroglandular. And when it's of mixed appearance, low and high echoes, it's called heterogeneous ecotexture. So we can go just next, please.
شايفة؟
It's complete
internet connection slightly disrupted.
from internet issue. So here, like different distribution of breast components. You see mostly it's fatty. A realist. Listening. I'm good. Fat, and here are the right upper fat component, and on the middle here the echoic areas, and here is uniform, and this is Is it clear?
أيوة.
So here it's more illustrated with red line, as we see on A. It's totally fatty. This is homogeneous architecture fat. And there, this is homogeneous on B and C of homogeneous. This is of same, B and C, they're like heterogeneous architecture. They're the same, and this is uniformly on D. Are you listening? It's very bad, actually.
Very good quality ultrasound images. Are those automated or handheld?
No, actually, these are website. It's not my own.
They are very good.
Like, you better have a good quality. Next time I will share my own cases. Inshallah, this is my first presentation.
Inshallah.
Inshallah. So this is when we're speaking about the density at the level of ultrasound. When we go for mammography, we have four descriptors according to the PIRATS. As we know, the breasts are almost entirely fatty. This is called ACR according to the American College of Radiology. This is called ACRA when it's almost entirely fatty. When it's cataphabloglandar tissue, it's called B and C for heterogeneous dense breast and D for extremely dense. Next, we go further to illustrate on the images. So here it's called like almost fatty, but it's less than 25%. From 25 to 50 distribution, it's called ACRB, and it's scattered when it's like 75. The maximum involves like less 75 or less from the breast tissue, from 50 to 75%. And totally, when it's more than 75% of the breast, it's called extremely dense. And this is more illustration on these diagrams for the distribution of the breast fibroglandar tissue to the fat. Next. Here, the two A and B are considered not dense breast, and these are dense breast. So what is the benefit from that? When we go more denser, it lost its sensitivity, and we need more to go for further imaging like ultrasound and MRI when we are practicing, and so it's more effort. And this is the dilemma of the dense breast. And also we have a problem that even denser breast, they are the main issue, and they are more prone for cancer. For cancer, ladies, they are more prone for that. The ladies of extremely dense breast. Next.
High incidence of cancers in dense breast, yes.
Yeah, high incidence in the dense breast, and this is the main problem. So we got analogs on mammography and ultrasound, which are common. For the MRI, it's a little bit later. I'm gonna speak about it. But so as we are in our routine practice, we go for ultrasound and mammography analogs. We have to clarify it more. Next. As we see here, for mostly glandular tissue, this is the uniformly glandular. This is homogeneous ecotexture fibroglandular. For a mixed density, it's like mimicking the ACRC. This is heterogeneously dense breast, and this is almost fatty. So this goes with ACRA, and this goes with ACRC, and this goes with ACRD. So these words are analogs for the mammography and ultrasound wording for each other. Next. Here is another illustration for the analogs. Here, look here, this is ACRD, extremely dense breast, and his goes with homogeneous ecotexture fibroglandular, and this goes with ACRC, homogeneous. This is heterogeneous ecotexture, like mixed ecogenicities. On the first one here, this is almost fatty. This goes here with homogeneous ecotexture fat. Next. So we have factor that increase breast density, so we have to be more cautious about it. Like hormone replacement therapy with ladies that on follow-up, I have to put it on my mind. They come, like they are all ladies and they come with denser breasts. I have to put on my mind they would be on treatment therapy. So most likely we goes for further sonographic imaging, and the pregnancy, which is actually it's contraindicated even to go for a mammography, and the lactation. Considering these two entities, we know that the pregnancy is contraindicated, although the dose of the radiation for the fetus is like unpredictable. But still, we have to think more. Can we get more benefit from that to go for mammography, or we can solve it with another, like ultrasound and MRI? Even now, you're there with automated ultrasound, or so a little bit far. The lactation, I guess it needs to go with the like an MDT. Are we getting benefit also or not? But it still is not, and even the breast is more sensitive. So these factors increase the breast. The weight loss, so that because there's reduction of the breast fat, it goes like more denser breast, not for the main appearance of it, just like it reduce the fat component, so it appears more denser. The breast cancer, like inflammatory breast cancer, it increased breast density and the inflammation like mastitis. So why we got these points? Because I have to think more and more, shall we go for mammography, or we can go for other entities to solve the problem? Shall I get benefit from the mammography when it goes with these situations, or I need to do like firstly this I guess it's from my practice. Sometimes I don't go with the guidelines, and I can just like take it, we clarify, and I take the ultrasound first. We don't have him right here, as you know, we are so far away, but still we're dealing with our situation. So sometimes we go, let's check the ultrasound first. If they're like I will get benefit from mammography, like I have a real mass, maybe sometimes the new machines you can get the calcification, and if there's ductal dilatation with intraductal hypogenicity, okay, maybe I need to see the calcification. So if I had the calcification, will I get benefit? Can I see it on the mammography with that very dense breast? I don't know.
Yeah.
Sometimes yani, we need a
Yes.
correction.
Yes.
Yeah.
You can.
Yeah. So
Calcification, you
yeah.
can. Yes.
Yes, I know we can see it firstly, but we have another problem that the patient tolerance for the mammography here. We don't know. We are so far away. You don't, we introduced the BIRAT system lately, like when the mammography, nobody knows the BIRAT system. We're so far away. So just like when you're working at some area, you have to speak their language to
Yeah.
take them step by step for your area. You can't rush the way we are rushing on breast imaging. So next, please. Also, there is factor that decrease the breast density that we prefer actually: age, postmenopausal state, and some medication, danazole, and vitamin D and calcium intake in premenopausal women. As you say, increasing age, the weight gain, and acromegaly. The weight gain, actually, we just gain more fat. Just it takes like more areas with fatty appearance may give a better contrast, like, but still the fibroglandular area is there. And the acromegaly next. So this is you speak about the density and the analogs, ultrasound and mammography. We go here for the reporting standards, what's called the BIRAT system. Now we are stopping forward, and we're still trying to, for the last 2 weeks, I have 2 sessions on a meeting that we're telling the doctors, the junior doctors from different disciplines, that we need you to know about the BIRATs and to understand what we're telling you. So, the breast imaging reporting data system is a standardized system so as to these categorization findings. The purpose is to standardize the breast findings to improve communication between us and other disciplines and the other breast carers or women imaging carers, so as to ensure that even the report have essential information that we are getting and auditing ourselves through that area. Also, it allow accurate tracking and comparison over time, but still we are lacking back, and hopefully we will get better. We have many issues that limits us, but we're getting better actually from the first time that we get mammography in Port Sudan. Now we are getting better, although we don't have that much screening, but it's still some people now like thinking about, shall we go for mammography? And then we talk about it several times. and it will be better, we know, for future, inshallah. So breast imaging, because it's a dilemma, so the ACR, as we know, they got in different wording and lexicon so as to be familiar internationally, so as to help and go further to just make it more easier, because it's complex. The breast issues are complex. Next, please. So we have mammography and ultrasound and even MRI lexicon. I just took it simply, and for the MRI, I just took like a little talk on the back of the presentation. As we know, first of all, I got to speak about the breast composition, either which ACR A, B, C, or D. And even when I go for D and C, you know that I have a justice for myself that, no, adjustment for myself that maybe it's okay if I didn't find the problem. Sometimes on my own practice, at the first time, I didn't get the lesions. But now I'm tracking the way Dr. Rabab and you all are helping us how to get on that area and how to compare it, and even how can I get the differences. For even more practice, you can let yourself getting even on the CND more properly on the dense breast. Other thing is when I get mass, I have to speak or comment on the shape, margin, and the density. As you know, there are certain words. For the shape now, the over, rounded, or irregular. So this actually, it's more easier. They omit some, I mean, the new virus, they omit some previous discriminators or descriptors. Okay, first of all, the mass, I need to speak about the shape, as you said, the margin and the density. These are 3 steps. When we practice more and more and more, you find yourself like goes like fluently, just like there's kida and kida and kida, when you adapt yourself for that and you stick for it. So the shape, 3 points. The margin, we have 5. Circumscribed, obscured, microlabelated, indistinct, speculated. These are the margins. So I'm asking myself when I'm reporting, which is which. Unfortunately, here we got the breast cancer very late. So most of the ladies, they come for diagnostic and we goes for this distribution, unfortunately. The density, fat, low, equal, and high. So when it goes for that, even here, when it goes from oval to the irregular, the margin to the speculated, and the density to the high density, this means more cellularity. This goes with higher and more possibility of malignancy. Considering so suppose just like I get a mass. Okay, this is a mass. Thank God I got something. We didn't get a mass. You have to look for another things. I've got symmetry, asymmetry, and we have 4 types of symmetry. Asymmetry, we have asymmetry, global, focal, and developing asymmetry. And even though we go there, when we go for developing asymmetry, if you compare the previous mammographies, the developing asymmetry is the worst one. So this let you ring a bell on your mind, and this lady need more focusing. And then architectural distortion. Maybe I found architectural distortion together with the mass, or maybe there's no mass, but I have an architectural distortion. What's architectural distortion and what's the difference between it and the mass? The architectural distortion is like abdominal parenchyma, but I can't get a mass. The difference is the architectural distortion, I can get
magnetic resonance cholangiopancreatic.
What? Sorry? Okay.
It could be just in the background. You can continue.
It's okay. So what is the difference? Suppose that I didn't get a mass and I have an architectural distortion only. The difference between the architectural distortion and the mass are the borders and the center. The center on architectural distortion will be of lower density, not high density like a mass, and it will have concave or retracted borders, while the mass will have convex borders. So when we get architectural distortion, this is actually, I guess, this is the area we are talking about. We're searching for architectural distortion and classification. When it's a mass, okay, this is a mass, let's deal and go. It's very obvious. But actually, we are looking for architectural distortion and the classification, and what are these caused by. Okay, the classification, we speak classification about morphology and distribution. We have actually typically benign classification and suspicious calcification, and then when we clarify which type of calcification, we go for the distribution, and this is raised more higher, or I can step more back on their classification. Then after I complete my wordings, I will search for associated features like skin retraction. It's either when so I have to just look actively and compare the skin throughout the images, upper, lower, periareolar, and even the hidden area, inframammary area, and the throughout. You have to compare. You take a zoom and you took a zoom and you measure the skin. Maximum is like 0.2. If there's nipple retraction, and make sure that the image is optimum and the nipple in profile, so as not to miss it as a mass. And maybe sometimes you feel like it's retracted, and it could be just it was not pulled properly in the exam. So you can, when you compare the MLO and CC, you have to make sure about the nipple situation. Sometimes it's like just technical issue. And then even we check for skin trabecular thickening, and axillary adenopathy or architectural distortion of the axilla, and even calcification of the axilla. This is mammography lexicon that we use too, and accordingly, when we go deeper and for more on describing, we go and take them higher to a higher level, and that is suspicious mass. Okay, we have an ultrasound lexicon. As we know, the composition and with the analog as we speak, homogeneous, and heterogeneous. Homogeneous fat, homogeneous fibroglandule, and heterogeneous. These are the composition considering ultrasound. Here, I think on my area here, I didn't used to write it because I guess they're not understanding me yet. After October, inshallah, I will introduce it on my reports. So like I'm taking it slowly. Now they are all familiar with BI-RADS, and they ask me, even non-surgeons, they used to ask, please ultrasound with BI-RADS, and they like, okay, yeah, you're already doing it. Thank God you're asking. So the next point is about the mass and the ultrasound. The mass on the ultrasound, we speak about shape, margin, and the either in the ultrasound we speak about the shape and the margin. This is the mass. We take it at the shape, margin. I guess you go far. Shape and the margin, orientation, and echo pattern on the posterior feature for each one. The calcification, nowadays the ultrasound machines can get the calcification, also the associated feature as we mentioned, and the special cases, we know that the cyst and so on. Okay, these are special cases like the cyst, it's anechoic, and this we know the fibroadenoma and the cancer. These are the differences. This is totally circumscribed. This is, oh, I'm safe. I'm gonna take it like virus 2. This is hypoechoic, circumscribed, as we mentioned here. When I speak about the shape, it's oval, circumscribed, and oriented parallel to the skin. And there is posterior enhancement. It's very nice. Oh, this is fibroadenoma. Like, okay. So here, this is our issue. This is cancer. This is irregular, as we said so, and this is the shape is irregular, and the speculated margin, and this acoustic shadowing posteriorly. This is very deeper. That means there is cellularity. There is high cellularity here, and this is goes with malignancy that we are searching for. Although fibroadenoma now is a real dilemma for me and most of us, but next time hopefully we get more talk about it. Because actually we got microlobulations more than 3 several times here. I don't know. I don't have records about the histopathology. Even I'm tracking them and chasing them, but I didn't get them yet. Hopefully they got closer. And now here, this is the hypercalc. This is glandular tissue. And by the way, my mentor, Dr. Rabat, several times she told me we got hypercalcic cancer. But I don't think that makes we get hypergonic cancer, and this is when we get on
You
the
have it?
mammography more vascularity.
Read.
No. In a case hypercalcic, yes.
What
So
is
we
the
got
impression
some.
quickly?
You're with me, doctor? So this is the final categorization, as we know, from 0 to 6. For 0, it's
But
more
that's all.
assessment,
Would
additional
you
imaging,
please,
and
all of us, close our mic so to avoid
so
background noise?
Okay, this is done by who?
we go collectively for the
Okay.
BIRAS system. We go
Thank you.
for assessment. When we took 0, we know that you need more and more, whatever. If I need to compare it with the previous image, if I need to go further for another study, whatever we started, which is which. So we didn't get we are there. By the way, sometimes I need to take it like Byra Zero, but still we're working in a very tough area and they go far away from us. So just for the sake of the patient and me, sometimes I get a Byrat like gray zone. I'm not comfortable with that, but so I sometimes we take the surgeon, please, I put it like this Byrat for you, so as I think this patient will not come again. We have a very big issue for that. They think like أنا جابني شنو أساسا. You get the point? Maybe financial issue, maybe I don't know. So they're affected.
I get
So
your point
considering zero,
totally.
yeah, exactly. exactly. أنا اللي جابني هنا. Actually, this is a real dilemma هنا احنا بنعاني منها. Okay, one, this is negative, and thank God this is go for retina screening, as you know, the benign retina screening. Probably benign. This is the dilemma of all the MDT and even us and even everybody. So it needs short interval follow-ups. By the way, I have a colleague. She was very young. She was 30 something. I put her by that 3. I told her she needs follow-up after 3 months. Unfortunately, she's a colleague. She told me that you told me you need a follow-up because she have a previous ultrasound. The size was not that much, but it was microrelated and put it like fibroadenoma. I told her that you need further workup. I guess if you're going everywhere, you need to do an MRI. Unfortunately, she came with metastatic breast cancer after 1.5 years. She's my colleague. She's a
Very
doctor.
sad.
Unfortunately, she was يعني even the educated. We
They are
go,
the worst. I'm sorry
yeah,
to
yeah.
interrupt, but they are the worst.
Exactly, Dr. Nadia.
Right.
Actually, she's my colleague. She's my own colleague. And when I saw the report, I told her, you need a short
They
interval.
like
You
to
have to
hear
come for
what
me.
they want to hear.
Exactly. And
They like
wallahi, she
to
came
they
bigger,
like to
huge.
hear what they want to
Exactly,
hear.
wallahi. Ay, wallahi.
Yeah.
She was very
Not
disastrous for
what
me.
is the real,
Ay,
what is
wallahi.
the real and what is
Exactly.
the real assessment categories. But they
Yes.
want to hear from you. It is 1
That
or
you're
2.
okay. You're okay.
Yeah,
Ay.
or maximum 3.
She
Not
came after
beyond
one
that.
and a half year. She traveled abroad. When she came, it's very يعني حصل له gross بطريقة غير طبيعية وحصل لها metastasis, unfortunately. طيب, stage 4 is suspicious. We go for tissue diagnosis and it goes in 4 A, B, and C. And now we have a highly suspicious tissue diagnosis, and 6, it's proven. 6 here, okay. Here when sometimes when we get 6, even we go mammography and the mammography, the other breast, when they go with MRM, I mean, they come with the fatty breast, but I used to do the ultrasound for the surgical bed, and I have 2 patients with surgical bed recurrence actually. While the right breast was totally fatty, I got 2 patients with local recurrence. 2 patients with local recurrence, and they were MRM. So even if it's fatty, I bring the patients for targeted exam for the surgical bed. Next, please. Next. So these are about the BARA system. These are like hints about the MRI. It's a big area in our situations. So, but I guess it's a screening tool, and it's safe for the high-risk patients with dense breast, the younger ladies, because in Sudan, I don't know what's going on. We have 30s ladies with breast cancer. We need to, I guess, to يعني to introduce the MRI strongly and to go for even the automated, we have to, as I heard before, the automated ultrasound with the screening tool, we need, I don't know how we're going to do it, but hopefully it's very hard, like, and we need it because most of the patients in Sudan, they are different. We don't have most of them like elderly as we know, but we have very young ladies with breast cancer. Now they are in like 40 something, and now they are on follow up. They told me that I have 5 years and 10 years, so they came very early with breast cancer. So now, for interpretation of the breast MRI, we distinguish suspicious lesion from background of parenchyma enhancement. This is the mainstay on MRI. This point, we need to scan the patient on the after the second day, I guess, after menstrual cycle, because the hormonal effect may affect the enhancement pattern, and it's maybe a little bit confusing. Next. Why I get the MRI here? Because so we on the MRI we go further so as to we review the clinical history and then the technical contrast issues, and we review them. We characterize the lesion on multiphases, mainly with T1, the curve. we evaluate the curves, and even we correlate with T2 mainly. After reviewing the whole images, we have to go for T2. The kinetic data. T2 is the mainstay, I guess. We go back for it. I don't know if somebody can يعني يشوف أنا حسب ما قريت إنه T2 the mainstay بعد ما راجع كل الحاجات. طيب comparing with prior studies and review other structure included on the field, like even يعني
You are
like
correct. You are correct,
yes,
Rehab. Yes.
yes.
Yeah, it is يعني it is a peers of MRI along with post contrast can solve most يعني أو can characterize most of the lesions, most, not all, but most of the lesion can be characterized only by T2 and post contrast study.
Yeah, as I have the T2, if the low signal lesions goes with the malignancy, and the high signal lesions goes with benign.
Generally,
high
low
cellularity.
yeah,
Yes, high
generally
cellularity, yes.
Generally low T2 is suspicious.
So thank
along
you,
with
yes.
morphology, along with morphology. But if you attended my lecture last symposium talking about the pitfalls of high T2, okay? Yeah, cancer can also be high T2.
Tamam.
High on T2,
okay.
yeah.
So that works. Okay, can you go next, please? Next. So this points about MRI here. Here the like a lexicon of the Barats here. The analog for breast density. This is almost fatty. This is scattered fibroglandular tissue, and this is heterogeneous fibroglandular, and this is extreme fibroglandular tissue. These are analogs for ACR A, B, and C and D on the MRI. And there here the enhancement pattern. This is minimal. This is mild, the multinodular multifoci enhancement. This is moderate, and this is marked enhancement. This could be in a normal lactating lady, but so that we have to be very cautious about the enhancement pattern, the kinetics. So next. These are like small point words about architectural distortion, and this axillary lymph nodes, nipple retraction, and this is skin tethering here, pectoralis muscle invasion, skin invasion, and here is the skin thickening, that these features mimicking the mammography, and all those we have to get the mammography with us, so as to when you are reporting MRI, mammography should be with us even though. Next. So reporting standards, next please. Now as we go there, just like a quick review, these are the descriptors. Go just next: oval and irregular, and so. And these are the margins: circumscribed, obscured, maculated, indistinct, and speculated. Next. You can go just faster, this is low and going to the high. As we see here, these are two examples of low density lesions. This could be oil cysts or even hematomas or fat containing lesions. So it goes with benign. Now, when we go for asymmetry, as we saw, asymmetry, when seen in one projection, focal asymmetry in two projection, global and developing. All the three seen in two views, projections, sorry. Next. And here is an example for this focal asymmetry. Next. An upper outer quadrant, as you see. Here the classification and the type of classification. As we clarify, these are the type of typically benign classification. But as we heard, for dystrophic classification, we have to search underneath of it. Sometimes you get something. It's not about the classification. You have to search more. Next. So these are the mainstay we are looking for. Amorphous classification. This is like scattered. So this is amorphous, but okay, this is DCIS. Fine polymorphic, coarse heterogeneous, fine linear, and fine linear branching. When we go here, this is the worst one. This is but like BIRATS 4C and the other BIRATS 4B. Next. So this about the distribution, as you see here, this is diffuse. This is most likely benign. This is regional. This is group, linear, and segmental. When we go there, these are the worst. So the linear branching is the worst one. Next. Now here, like when we found here, this is partial obscured mass here with circumscribed, partial circumscribed border. And of its equal density, when we go for ultrasound, there is oval circumscribed with posterior enhancement, 2 lesions. We found here 2 lesions, and it goes with cyst, and this is benign. Next. Here we go for another one. As we see here, there outer, lower to central, posterior third mass of higher density lesion, as we find in the ultrasound here. It was hypoechoic, like lobulated mass with posterior shadowing. This could be like could be a fibroadenoma. Next. But still it's suspicious, so it needs a short-term follow-up for me. Here, this is upper outer high density irregular speculated mass with associated skin tethering, and I guess there is even lesional calcification. When go for ultrasound, it's irregular speculated with posterior acoustic shadowing, very dark shadow, and it's very dark even with adjacent architectural distortion. This is highly suspicious by BIRATS 5. Next. So when we need for the standard reporting, as we mentioned there, we first of all we put the indication, the breast composition from A to D according to the modality that we are using, and now we spoke about the analogs. Then the important findings accordingly, mass, asymmetry, architectural distortion, classification, and other features. We compare with previous study if there is. And the final assessment category, we give the management recommendation and then communicate unsuspected findings with the referring clinician. And this is the mainstay here. As we're struggling, the patients are very simple and very, like illiteracy. And this is our main problem. Next. So taking home message. I guess breast cancer is a dilemma. For our situation, it's a very big problem. We're facing like new modalities. In the world, we're trying to catch them up, but actually we need more steps. And we are talking about early detection of breast cancer. You know, some patients come with ulcerating breast cancer, and some patients come, by the way, I have like 3 patients. She came with like part of my breast وجع كده بس. You can't imagine how much we are so far away. Hopefully we'll get better إن شاء الله soon وترجع بلدنا معافية بإذن الله. Thank you
إن
for your
شاء
attention.
الله.
Appreciate.
Insightful. Very, very, very nice presentation. Thank you very much for your interaction, presentation, notes, and you were so informative and to the point. Thank you very much.
Thank you,
Appreciate
thank you,
it.
Rehab, my daughter. This
أنا
is
في
one
العربية
of
طبعا في الشارع.
yeah, دي من بناتي الأوائل يا أوائل جدا من
والله يا دكتورة بابا الله يديك
2018
العافية.
يا أيوه
الله يديك
أيوه
العافية إن شاء الله ما نعدمك طولة بال غير طبيعي. إحنا مكتسين والله وضعنا شوية صعب في البلد لكن الحمد لله رب العالمين ما قاعد تخلينا. الله يديك العافية.
الله يعافيك
الله
الله
يكرمك يا
يعافيك
بص. الله يديم عطاك
اللهم
ويديك
آمين
الصحة والعافية يا رب ويكرمك
جمعا جمعا
في الدارين يا
جمعا
Thank
الله.
you so much. Thank you so much. And
جمعا
it took me
رحب
back when
دي
we
من
started.
من المميزين والآن
ما شاء
يشاروا
الله.
إليها بالبنان في السودان وبيمشوا لها
الحمد لله.
برنيم بيمشوا
ما
لها
شاء الله.
بالاسم الآن حاليا
بفضلكم بعد ربنا الحمد لله رب
بيجيني
العالمين.
منها excellent
الله
report.
يديكم العافية إن شاء الله.
يعني بيرجعوا
You
لي
إن
took
شاء
في
me
الله.
back
الواتساب excellent
لبداية
report.
الشغل
الحمد
حقي لأنه
لله.
البريست
We're trying to
لما
write
كنا
it.
نجي داخلين القسم في ستات، أنا كنت من الباب بعرف إنه في عينة بتاعت ماستكتمي من الريحة. So what you said at the end, it took me back. We are back there.
Yeah, because they are coming يعني too much late. مش late,
As a
like too
fungating
much
mass,
late.
yes.
Exactly,
It was
exactly.
actually they are toilet mastectomies. They are not mastectomies for
أيوة
treatment.
أيوة والله.
Actually
But
فعلا
we are back to that.
لكن
يعني الكلام ده في أول التسعينات. يعني نحن we are back to that. That is very sad.
أنت عارفة
والآن
إحنا بعيدين شديد هنا
هم
بورسودان بالذات.
هسه ناس رحاب بيرسلوا الماموس بتاعتهم هسه في العيادات المجانية. أنا يا دوب نزلت لكم 2 كيس يعني كده خفيفات في الجروب يعني، لكن عندهم ماستكتوميز وريكارنس وحاجات عجيبة يعني. فربنا يعينهم ويقويهم
آمين
ويتقبل
آمين يا
منهم،
رب.
ربنا يتقبل. لكن قصدت أوريكم إنه الآن أنا يعني بيقولوا لي يعني مشينا لدكتور رحاب توصينا، أقول لهم خلاص مشيت لدكتور رحاب تاني فمش وين يعني.
الله يديك العافية يا بص. الله يكرمك والله شهادة. الله يكرمك يا رب.
وصلت لا
الله
والله
يكرمك.
ما عشان قدامك، لكن
الله
حقيقة
يكرمك.
من الريبورت اللي بتجي يعني ما
الحمد لله.
بيرسلوا لي الريبورت اللي انت كاتباه مع الصور خلاص
أيوة.
يعني
الله يديك
تاني
العافية يا بص.
no need انه you did a good job وربنا يتقبل منك، لانه
الله
انتوا
يديك العافية يا بص. شكرا
القابضين على الجمر في السودان.
يديك العافية يا بص.
الحمد
تسلمي
لله.
كتر خيركم. شكرا على
Thank
صبركم.
you.
الله يديكم العافية.
Hopefully,
الله
Rabab, we
شكرا.
can have a private talk. You can update me what is happening in Port Sudan in my area also.
طيب عندكم تاني نادية انت قلتي شنو؟ انا سمعتك من بعيد.
I was asking Rabab that we can have a private talk since she's in Port Sudan.
رحاب يومين رحاب.
جدا
Yeah.
جدا يا بص جدا.
Because I have mixed informations about Port Sudan. أصلا هي كانت من زمان backward في الhistopathology.
أيوة شديد شديد يا بص. شديد والله.
خلاص we can have a private talk. I'll send
sure.
my number is in the group.
اوكي يا بص ابشري.
طوالي.
الله يديك العافية يا رب.
And keep
تسلمي.
up. الله يغطي عليكم.
تسلمي حبيبتي. الله يديك العافية يا رب.
شكرا لك. شكرا.
الله يخليك. تسلمي. الله معكم.
شكرا جزيلا يا رحاب.
تسلمي حبيبتي. شكرا. الله معكم.
إسراء over to you.
شكرا جزيلا دكتورة رحاب for the very nice presentation. Now we stay with Dr. Anas Hamdoun, consultant radiologist, University of Calgary, Canada, for the closing remarks. Dr. Anas, are you here?
He was here.
أيوة كان موجود.
أيوة.
غالبا هو موجود هسه. أشوفه كده في أيوة موجود. موجود بس احتمال مشى أوي ولا حاجة، لكن المايك بتاعه فاتح.
أيوة فيها.
أيوة.
السلام عليكم.
وعليكم السلام يا أمل.
كيف الحال؟ بالإذن لحد ما يدخل دكتور أنس.
لا
حابة
جدا
أشكر
طوالي.
الجميع.
we can make use of time.
أيوة، وبالأخص يعني
تفضلي
دكتورة
أمل.
رباب شكرتنا كلنا، لكن في الحقيقة هي اللي بتستحق أن نشكرها، لأنه هي شجعتنا وهي دائما واقفة وما شاء الله عليها، يعني عطاء يعني تبارك الله. إن شاء الله يكون صدقة جارية ليك ولوالديك ودائما ينفع بيك الناس. يعني احنا بجد ودائما بنحس انه نحن في فريندلي انفايرمنت، يعني مهما تبعد بتجي راجع وبتكون بتكمل السيشنز لحد النهايه وبتكون يعني extremely interested. فبجد الشكر لك ولكل الاساتذه ولكل الحضور.
شكرا لكم انتوا والله يا أمل. شكرا لكم
وعليكم
انتوا
السلام
جميعا.
ورحمة الله دكتور أنس.
عاجزة عن الشكر.
وعليكم السلام ورحمة
مرحبا.
الله وبركاته. ألو.
أهلا
طبعا
أهلا
أنا
وسهلا،
زي جماعة
مرحبا
أنا
بك.
الدفعة. أنا ده دفعتي يا شباب.
أهلا وسهلا.
هي بروف أنس لكنه دفعتي.
بختكم
لا
ببعض
ما
والله ما شاء الله.
ما بروف ما بقيت بروف خالص.
لا إن شاء الله قريبا بروف إن شاء الله.
إن
لو
شاء الله.
ما بروف في مكان البروف.
الله يبارك فيك، شكرا لك.
الله يكرمك يا رب.
الفيديو شغال؟ أنا شايف ما.
لا ريكوردد.
لا ما أنت عملت شير.
أنا
لا،
شيرت بس
هي
الكلوزين
شيرتني.
الصفحة.
المفروض أنا لما أكون اكتيفيتنج الفيديو يظهر ما ظاهر معي.
خليني بس أرجع أشوف
أيوة، لأنه أنا مشير لكن شكله لسه ما عندي.
أنا أعمل لك أطلع برا من الشير. طيب end سلايد شو. يلا أنت ممكن تشير الآن. stop
طيب.
share.
بس كده يا خلاص.
خليني أعمل لك كوهوست. دقيقة يا دكتور أنس.
لا أنا ما عندي هنا، ما عندي سكرين، يعني ما عامل سلايدز.
لا ظاهرة الكاميرا ظاهرة شايفينك.
أيوة.
خلاص إذا نخلي
لا
السلايد بتاعته عشان يكون معرف إنه ده دكتور أنس مع الصورة
خلاص تمام.
بتاعته.
خلاص كويس أوكي.
دي أنا. أيوه أنا يا حبيبي.
وين العسل ده؟
هاي طبعا. سوري
يلا
ما
وين يا
انتبهت
دكتور
عليك.
أنس؟
يلا كده اختفت الصورة، بس ما عشان ما بقدر أضبط. ظاهر أنا الصورة بتاعتي.
أيوة ظاهرة. أنت عايز نشير الفيديو
لا خلاص،
كامل
لا
أفضل.
ممتاز. لا ممتاز. طيب أنا كنت مفتكر إنه حكون شايف ماي اون فيديو شير، لكن خلاص شغال صوت، مش كده؟ أعمل ميوتنج للفيديو حقي.
أنا ممكن أشير
لا ما تعمل ميوت يا دكتور أنس. خليك صورة وكاميرا الاثنين.
يعني أنا ما شايف صورتي، لكن
هاي كده شايفينك.
خليني أعمل
خلاص
لك ستوب شير.
احنا شايفينك لكن انت ما بتقدر تشوف روحك.
خلاص، بس عشان أوزن الكاميرا، بس لأنه أنا شغال من جوال. إذا موزونة خلاص كده
موزونة، هاي موزونة.
خلاص جيبي الصفحة بتاعتك الجبال عادي.
غلطت الصفحة عشان تكون معاه ومع بعض. مرحب بك يا دكتور أنس. الله
الله
يعطيك
يبارك
الصحة
فيك، الله
والعافية.
يسلمكم. أيوة أنا
جزاك
توقعت
الله
خير.
خير لقبول المشاركة.
الله يسلمك. Shall I start?
أيوة إحنا شايفينك تمام.
طيب، بسم الله والحمد لله والصلاة والسلام على رسول الله. First of all, I'd like to thank the organizing committee for giving me this opportunity on behalf of the radiology groups to deliver the closing remarks for this magnificent symposium, which I managed to attend most of its presentations. Before that, I would like to thank the organizing committee for the great efforts which has been made before the beginning of October, and also for the last few years, where they were continuing to give their great efforts and work despite the war in Sudan, and despite the difficulties our people were having, especially those who are still under stress in the remote states of Sudan, where they are still doing great work to participate in this program every year. And we were following their campaigns, their lectures, and their teaching for their own people. I would like also to give my gratitude and thankfulness to the efforts which has been done by the presenters. Actually, I noticed that this year there is great effort from those who we consider them are newcomers in the playground of radiology. Actually, they were great. They were magnificent. They delivered very nice. And I myself, I enjoyed the talks which were given. They were very informative and well prepared. I hope this program will be recorded, and the radiology registrars will benefit from the nice lectures, which were very comprehensive. They covered actually all the aspects of breast imaging, starting from pediatric to adult, from all the imaging modalities, from all the classic techniques and applications to the very advanced techniques. Actually, it was a great work. I enjoyed it very, very much, and I hope this will be continued for next years. And also, I have a dream. I would like to share it with you. I hope by next year, all the hospitals in Sudan, in all the states of Sudan, will have screening programs, will have good mammography machines, state-of-the-art machines. They will have very good services. They will have biopsy for breast cancers, and also the oncology centers will increase. Instead of being 3 or 4, inshallah, next year, it will be all the states of Sudan will have their own service. And inshallah, next October, we would like to do this effort with more practical approaches and more participation from the Sudanese component. I mean, even in the remote areas, in Niala and in Al Fashir and all the parts of our beloved Sudan, because this can be, actually, it's not only a dream, but it can be a reality because of one thing, because we all work together, because we all believe in each other, because we all support each other, because we believe that this work cannot be into existence unless we push too hard for it to continue and to become even more and more better, more and more advanced. Inshallah, as I said, next year we need to celebrate and to have all the programs and all the campaigns in all over the country, inshallah. Thank you again for giving me this chance to deliver the closing remarks. Thank you for all the participants. And also, I would like to thank the multidisciplinary team who delivered the previous symposium of early detection, which was also unbelievable, was very nice. I managed to attend most of its programs. Again, I would like to thank all the people who were behind the scenes, and they did great work in preparing the slides and in making this thing happening. Thank you again. وجزاكم الله خير. السلام عليكم ورحمة الله وبركاته.
Thank you very much, Dr. Anas. Thank you very much for this warm and grateful presentation and talk. Thank you very much. We are sharing you the same dream. We wish all this will come down and we will see our country in better rising. Thank you very much. So, Dr.
Thank you.
Rabab. So before closing, I will just want to ask if anyone want to have final talk.
I'll give you what. Get the whole box.
So we are going to close our nice day two, end of day two symposium.
Hello.
What an incredible. Hello, yes.
Hello.
Hello.
Hello. السلام عليكم.
وعليكم السلام ورحمة
ما شاء
الله.
الله. ما شاء الله.
تسمعوني؟
حضر الماء وبطل التيمم.
السلام عليكم.
ما شاء
وعليكم
الله
السلام
أستاذ
ورحمة
العزيز.
الله.
كيف الأحوال؟ مشتاقين يعني.
بالأكثر حبيبنا. الله يبارك فيك أستاذنا العزيز.
طيب عشان ما أخذ وقت كثير من الشباب ديل، وهم عملوا ماراثون، الحقيقة ماراثون كامل طويل 30 ميل، ويعني أنا محتار دلوقتي. أنا تابعته الحقيقة، ما قدرت كل الوقت لكن معظم الوقت أنا تابعت المجهود ونظرت إليه بعين فاحصة شديدة وأذن صاغية عشان أتعلم منه، وعين فاحصة عشان أشوف how can be made better. فوجدت أنا محتار، نشيد بياته يعني أشكر ياته وأهنئ منه. يعني هل أهنئ الناس اللي هم على الجمر، الشابات الرائعات على الجنب في الأبيض، في كسلة وفي الشمالية وبورسودان، ولا أهنئ يعني الطيور، طيور السعد المهاجرة في بقاع الأرض المختلفة اللي استقر منهم وانتزعوا مواقعهم في الناشونال هيلث سيرفيس في بريطانيا، واللي في الكويت، واللي في الخليج في مواقع كثيرة جدا بأقدام ثابتين، وكمان الناس اللي حاملين يعني جراح الوطن وحايمين بها دلوقتي في الخارج ومنتظرين أنهم يرجعوا، ما رضوا أنه يلتصقوا بأي مكان آخر. ما أعرف أهني ياتو في ديل وأشيد بياتو في ديل. وكمان برضو يعني المسألة شوية يعني كبيرة، اللي حصل دي شيء غير عادي. يعني كونك تستمع إلى خريجين جدد وبيتكلموا بثبات وبثقة وبوعي وبمعرفية عالية، ده شيء يعني زي بيقول شنو اتولد بسنونه، وده يعني شيء رائع. يعني ده دي توجه جديد. يبدو انه الحرب قد صهرت الناس وصهرت عقولهم وانتجت احسن ما فيهم. صحيح انتجت اسوأ ما في بعض الناس، لكنها في شبابنا انتجت احسن ما فيهم. فاللي شفناه ده شيء رائع، شيء عظيم، شيء موثق، شيء هادئ. بعدين بعيد من الأضواء، بعيد من البريق، بعيد من البهرج. يعني الإنسان لما يتحدث إلى 18 شخص ويتحدث بإخلاص وصبر طويل، هذا بعيد عن أنا أعرف معنى البريق لأثره عند الناس وجاذبيته عند المهنيين، لكن هذه الكوكبة من الزهرات اليانعات بعيد عن كل هذا، هم قدموا عمل طيب وعمل علمي. أنا أشيد بما جرى، وأسأل الله أنه كل واحدة يوفق ربنا بأكثر وأكثر مما هي قدمت. الشيء الأخير اللي أعلق عليه هو التناسق ده والتعاون ده. دي ما أزمة بلدنا يعني عموما في العلم وفي السياسة وفي الإدارة وفي عدم تعاون الناس مع بعض. حتى أنا في الحلقة الماضية قلت أنا كنت محتار who is the pathologist who is the radiologist. الباثولوجيست عندنا بيتكلموا عن الراديولوجي بمنتهى التفاصيل وبالكلاس والسب كلاسز، تمام. والراديولوجيست عندنا بيتكلموا عن الباثولوجي. مزاج جميل جدا جدا. أخيرا يعني بنتنا الرباب ما شاء الله عليها، وطبعا هي صح دفعة أنس، لكن يعني نحن بنعتبرها أصغر منه يعني في العمر وكذا. نطلع أنس زول كبير عجوز، عشان أنا عمري ينقص شوية. لما أقول أنس كمان كبير ما أقدر أقول أنا امتحنت ولا درست وكذا، بقى أنا كبير. طولت
أنا
عليكم وشكرا جزيلا، شكرا جزيلا، والله يوفقكم ونلتقي كثير إن شاء الله. keep on this good job, keep this good job و keep these good relations مع بعض. أنا متأثر كثير جدا بما سمعت. السلام عليكم.
يا سلام يا سلام. يعني هذه مسك الختام.
والله
يعني
أدمعت عيناي.
أي والله، أي
كلام
والله،
عظيم، كلام يعني
والله كلام،
صادق.
كلام من الشخص الصح في الزمن الصح.
يا سلام.
إن شاء الله يعني الرسالة دي تصل لكل الناس، ويعني الروح زي ما قال البروف بدوا بها الناس يواصلوا بها، والشغل الطيب ده ما ينتهي. فربنا يجزيه كل خير البروف على هذه الكلمات الطيبات. وصحيح يعني هؤلاء الكوكبة يستاهلن كل خير، ما نملك إلا أن ندعو لهن إن رب سبحانه وتعالى يبارك فيهن ويبارك لهن ويبارك بهن ويبارك عليهن إن شاء الله.
الله يكرمك يا دكتور أنس.
الله يبارك فيك.
اللهم آمين.
عفوا فاتت علي حاجة أخيرة لو سمحتوا.
أيوة طوالي.
تعرف يا أنس، نحن يعني كآباء لازم يعني ننشد في البنات والأبناء ما هو يعني أكثر وأعلى. الشيء ناقص في الكوكبة دي عدم الكتابة. وأنا كلمت رباب كثير جدا، وهسي أنا بلويمة قدامكم هنا، قلت لها لازم تكتبي، لازم تكتبي. الكتابة دي محقق على نفسك ل3 أسباب. أولا you promote yourself. 2 أنت لما تكتب بتحمل اسم اليونيفرسيتي بتاعتك والمستشفى بتاعك ومركز الثدي بتاعك وإلى آخره، واسم البلد بتحمله إلى العالم. وده واجبنا، نحن نار غايبين من خريطة العالم علميا. وحاضرين طبعا، حاضرين بصورة أخرى. كل الناس اللي قدموا الليلة مؤهلين عشان يكتبوا كتابات رائعة، كيس ريبورتس، كيس سيريز، opinions, letters to the editor, review articles. You are all quite able to write. ونحن واجبنا، أنس وأنا واجبنا نحن نساعدكم. اللي عايز فيكم يكتب نحن بنساعده، واللي ما حيكتب نحن هنعاقبه بعد كده. ويا رباب استعدي، أنا هعمل عليك غرامة مالية النهاردة. السلام عليكم.
يا سلام.
So true. We always forget to document. This is such a waste of knowledge.
صحيح.
الناس دايشة في الدوامة بتاعت الحياة اللي ما بتنتهي، مع إنه الناس
برضه لكن it's not
أغلب الناس
excuse برضه.
شغالة على الحاجات
But
التانية أكتر.
it is the
والله
right.
أنا يا
It is
جماعة
one
في
of
الختام
your
الشبكة بتطلعني every يعني 1 minute الشبكة بتطلعني وبرجع، فبتطلعني وبرجع. سمعت البروف بيقول عقوبة، حفرض عقوبة على دكتور رباب. أنا طبعا اللي بتفرضه كله على راسي من فوق من غير ما أعرف السبب.
كيس ريبورت سريع يا دكتورة
بل
رب.
قال لك الكتابة.
لا
قال
الكتابة أنا
لك
ما كتبت،
الكتابة.
لكن ما موفقة في النشر، ما موفقة في النشر. ربنا
ده
يسهل،
بيستاهل،
نحاول ننشر اللي
بيستاهل.
اتكتبت، ننشر اللي اتكتبت دي إن شاء الله نواصل بإذن الله.
فكرة يا
إن شاء
دكتور، في بداية الكورونا
إن
كان
شاء الله.
علقتي على حاجة
إن شاء الله.
مهمة اللي هي المايكروثرومبوزيس. الكلام ده انت لما قلتيه كانت في الشهور الأولى من اكتشاف الكورونا، بعديها بإذن قريب شهرين حتى بعد ذاك انترناشونال بيجوا يتكلموا عن القصة دي. تتذكر الحتة دي؟ يعني دي كان المفروض
أيوة صح حقيقة.
يعني
ما
لا
كان
أنا
في
في حالة
وقتها
تانية.
ناس المستشفى كان ما سمحوا لي. أنا كنت جمعت
لا
الكيسين وناس المستشفى رفضوا لي إني أكتبها، حتى بعد ذاك
في
هي
كيس
طلعت.
تاني يا رباب، في كيس تاني يا رباب
أيوة
ما كتبتيها،
جاهزة
اللي عليها
موجودة يا
عليها
برو،
الغرامة، عليها
موجودة.
الغرامة دي
هي موجودة، أنت قلت لي دي كيس ريفيو، وهي جاهزة الآن، جاهزة بس تنشر وين؟ جاهزة موجودة، ما ولا محتاجة أي شيء. الحين لو حابة أرسل لك بعيد لك رسالة تاني ريدي
immediately.
بتاعت
يا
يا
بروف
ولا
ازيك؟
كيس اتفضلي 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 يا نادية. بعدين
بروف ازيك؟
أهلا مرحب.
نادية الضوي معك.
يا سلام يا سلام، استمع لك انا، ما انت انا قايل لك راديولوجيست من كثر الراديولوجي قلتيه لي.
والله ما شاء الله
لا
تبارك
لا
الله. نشيد.
نادية دي عضو
يرجع
مهم
للحياة.
معنا.
نعم كيف انا
اتقابلنا
سمعت
في السوبا.
ايوه
بتسك الباثولوجيست هي.
اكيد ما شاء الله ما شاء الله
واتقابلنا في
عليها.
السوبا وكليك توجذر. الحمد لله.
اتقابلنا في صوبة ربطنا العلم إن شاء الله ربنا
يا
ايوه
سلام
الحمد لله.
يدينا
يا
همة.
سلام.
يا
لا لا
يا ولا اتفضل يا
أيوة.
بروف، اتفضل يا بروف.
if you are serious عن الكتابة تمام،
ايوه
تكتبوا لي او تكتبوا لأنس، ده ما فيه الكفاية مما يؤكد حرصكم في very good idea, very good welcoming forum, very useful, very pertinent to our home country. I can suggest you and I will liaise it. بس يا أنس
اوكي
أنت اتأكد أنهم جادين، لأنه الناس اللي نفسهم قصير ديل ما بينفعوا في الكتابة، لازم يلتزموا. أيوة
يا بروف
التزموا. أنت
يا بروف
اشهد لي
بس تتنشر لي واحدة، تتنشر لي واحدة وانا ما بجي. انا كتبت كذا
طوال.
مرة لكن لحد هسه ما نشرتها ولا
أنا
حاجة.
برضو عندي واحدة جاهزة والله، ميل بريست
انا لو
كانسر.
اتنشرت لي ما بجيش تاني يا بروف.
طيب أنا
الكيس ريفيو اللي انت شفتها اللي قلت لي عليها it is ready. لو بس ساعدتني في انه انشرها تاني ما بجي.
جدا جدا جدا. الناس اللي عايزين المجلات أصبحت مزعجة في طلب النشر، مش
أيوة
العكس. يعني
صحيح.
في أكتر مما حتى في البريديترز دي الحايمين. فلازم
بيرجعوها كتير
موجود
والله، بيرجعوها كتير
المجال.
من زمان.
وفي فكرة كبيرة لو كلمتوا دكتور أنس، وأنس شهد لكم بأنه جاهزين، أنا بديه الفكرة الكبيرة دي نعملها شنو؟ فكرة very big idea.
ان شاء
خلاص
الله
يا دكتور
جاهزين. هم نشيطين بس عايزين تشجيع.
اما
خلاص
انا
أوكي.
عندي كيس
عايزين
ريفيو بتاعت
منترين.
يا ولا
نحن
يا ولا
بنرفع.
يا ولا.
أنا برفع
عارفه
يا
الكيس
رباب
شنو؟
لليوروبيان جورنال
سميتي
وبرجعوها.
ببريس هيرنيا؟ سميتي ببريس هيرنيا؟
سمعت بها منك انت.
بس دي كيس بتاعت بريس هيرنيا في السودان. طبعا السودان فيه حاجات ما انزل الله بها من السلطان.
نعم
بريس هيرنيا تروماتيك بريس هيرنيا
نعم.
جايه
أديكم
as
الاقتراح طيب.
suffocating mass.
ايوه
اتفضل يا
طوالي
برو،
يا حب.
أديكم الاقتراح.
ايوه احضر لنا
دكتور
اعلان صاغيه.
قول على
دكتور
الهواء.
أنس، أنت يا دكتور تشهد بأنهم خلاص هم يعني جادين خلاص.
لا
إذا
هم
شهدت
جادين.
فإنني
والله
سأقدم له.
جادين، نحن جادين
طيب
والله يا برو، جادين جدا
في
والله.
جيرنال
من
أوكي.
هنا
في
جمعياتنا كلنا معاك، كلنا معاك.
جدا. طيب خلاص انتوا نحن نقدم كلنا سوا، انس وانتوا ونحن وكل الحريصين نعمل سبيشال ايشو في جيرنال، كومبليت ايشو من الالف الى الياء.
ان شاء الله.
اوكي
طوالي.
مستعدين؟
نسميها سودانيز جورنال.
ما فهمنا، انا ما فهمت سودانيز جورنال يعني.
لا لسه هو ما
جيرنال
قال.
ايوه جيرنال، عدد كامل في مجله.
This is a
ممتاز
brilliant
جدا.
idea.
انا مستعد اجيب لكم الموافقه. نعم
موافقين
لا
طوالي
ممتاز،
والله.
موافقين طبعا.
خلاص اكتب، كل زول يكتب اول حاجه كوميتمنت، يكتب لنا رساله او يكتبها لدكتور انس. تمام، بانه والله انا انترستد انا اي ويش كده تو ببلش وكده 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 وكده، عشان احنا ما نشتغل بالافتراض، كل حاجه ذات تكون دوكيومنتد. اوكي
تمام انا جاهز.
ان شاء
يلا
الله.
انا بنسق مع دكتور انس.
الشباب يعني بس اديهم نبذه بسيطه. هم طبعا انت غني عن التعريف، لكن يعني اقول لهم انه الكلام ده ما اتقال من فراغ. البروف علاقاته ما شاء الله واسعه، وفي مجلات بيرسل له يعني عشان لو هو قال لنا كلمه معناه هو عارف بيقول في شنو.
ايوه
فدي معناها نشر مضمون.
Definitely.
حتى انا بقول لكم
ده
ف
بالنسبة للباقيين. طبعا بالنسبة لنا نحن يعني دي بالنسبة لنا نون يعني زيك واحد، لكن ده بالنسبة للآخرين الناس
ايوه
الجونيور اللي في
ايوه
الجروب.
صحيح.
الرسالة دي لكم القاعدة أنس دي. ها نحن طبعا كلنا عارفين البروف لما يقول كلام يهمني.
ايوه البروف هم المجلات بتستكتبوا، يعني بيطلبوا منه يكتب لهم، يعني ما شاء الله. فهو لما يقول كلام بشكل زي ده معناه خلاص احنا نجتهد، والايشو الكامل احنا ان شاء الله نكون على قدر المسؤوليه، والايديتنج والجايدنس والتكنيكاليتيز وهو بيساعدنا فيها. وانا اي ام ريدي تو يعني انه اكون حلقه وصل ان شاء الله، ودكتور رباب برضه موجوده. فان شاء الله الموضوع بيتم، يعني طالما بدا بالنيه الخالصه دي ان شاء الله
بإذن
كله
الله
مبديه متمومه.
ان شاء الله
ده كلام
ان شاء الله
بروميسنج
بإذن
شديد.
الله بإذن الله.
ان شاء الله.
الله يجزيكم
شكرا.
خير دكتور انس، دكتور
بإذن الله.
معتصم.
جزاكم الله خير، جزاكم الله خير
جزاكم الله
جميعا.
خير
مم.
أساتذتنا
وانا
الأجلاء.
عاجزه عن الشكر باختصار، يجيكم من الاخر كده عاجزه عن الشكر تماما، وقمه يعني سعادتي لا توصف بصراحه يعني.
ربنا يكملها ويتم.
وشكرا للبروف، وشكرا لماي كوليج دكتور انس، وشكرا لكم جميعا، ونتمنى انه نلتقي قريب.
شكرا لك دكتورة رباب، انت كمان.
شكرا. السلام عليكم.
الله
السلام.
يبارك فيك. السلام عليكم.
وعليكم السلام. وعليكم
شكرا
السلام. وعليكم
شكرا
السلام ورحمه الله.
الله يسلمك.
كتر خيركم.
الله يسلمك. الله يسلمك. الله يسلمك. الله يبارك.
خلاص احنا ما حنختم بعد كده، لانه اللي اتقال ده يعني ما بيتقال بعديه حاجة. فيا جماعة مع السلامة، ونلتقي قريب ان شاء الله.
ولا بس اقفل الريكوردينج.
اوكي.